Hello and welcome to Rácz Lab Virtual Live. We're so excited to have you all here, whether it's morning, afternoon, or evening, your time. We've got 22 countries represented, and we're excited to bring you a wonderful program. First, I want to just say thank you so much for your patience. And without further ado, I'm going to go ahead and introduce our first speaker, which is Dr. Andrea Trescot. She is going to talk about anatomy and physical exam of lysis patients. If you don't know Dr. Trescot, she is the founder of Pain School International. She is the past president of ACIP. She is the past president of Florida Society of Interventional Pain Physicians. She has authored over 150 peer-reviewed articles. She's also the author of a 900-page book on peripheral nerves. So without further ado, I'd like to go ahead and welcome our first speaker and guest, Dr. Andrea Trescot. Please feel free to use the chat box and ask her any questions, and she'll answer those at the end. Thank you again.
Should I go ahead and share my screen? Good morning. So, thank you, Tracy, for that lovely introduction. I'm going to go ahead. Unfortunately, my participant screen sharing is disabled, so I need to have access to share my screen. A minute. So, I am trying. There we go. Thank you. Okay. Well, good morning. Thank you again, Tracy, for the lovely introduction. I'm going to talk about the physical exam and the anatomy of adhesions. Just as a FYI, I am the chief medical officer of StimWave, which is an implantable stimulator company, but it won't have anything to do with this particular lecture. So we've got a patient, a 57-year-old male, status post-lumbar laminectomy in 2017, complains of persistent right leg pain. He noted good relief from the right leg pain after the laminectomy, but has had a gradual return of leg pain worse than it was, as well as midline low back pain. Repeat MRI was unremarkable, according to the surgeon. So I love this quote from John Lozier, who is a neurosurgeon. The magnitude of the problem, failed back surgery, is unclear, but it's far greater than the standard neurosurgery and orthopedic textbooks would lead the neophyte to believe. So what's going to be your first step? Well, for me, it's a physical exam. And that physical exam is looking for other causes of low back pain. Now, this particular patient had no facet tenderness. They had no posterior superior iliac spine tenderness, so not a sacroiliac problem. They did have a positive straight leg raise at about 30 degrees, and they had a dural tug at 4-5. And what is a dural tug sign? Well, nerve roots are supposed to move smoothly in the epidural space, and when you cause the patient to slump and then tilt their head forward, you put tension on those nerves. And if they're moving smoothly, it shouldn't hurt. But if it's stuck down, they should be able to actually point to where the problem is. And you can see here on the MRI, if you look very carefully, that the nerve roots are stuck down to the posterior, to the ligamentum flavum. And here you see the nerve root stuck down in its foramen, as opposed to the ones above where the nerve root is right in the center of the foramen. You see that this is stuck to the vertebral body. And that's because of inflammation. Now, we know that surgery will cause inflammation and adhesions, just like operating on the belly, but you can also have adhesions from leaking discs. And in 1989, McCarran took the disc material from the tail of dogs, blended it up, injected it into the epidural space, and here is what the spine looked when the control of saline was injected, and this is what it looked like after the injection of the nucleus pulposus. And in fact, if you look at it in color, even more dramatic, this incredible inflammatory response. And from that, as that resolves, you get the epidural adhesions that occur from it. And you can see those adhesions and the inflammation under spinal endoscopy. So what's the next step? Well, you certainly could do a lumbar epidural, but in this patient, because their surgery, because they're having symptoms at the level of their surgery, there's no epidural space in that, in where they're hurting. So you'd have to be going above, and medicine goes to the place of least resistance, which is away from the nerve. You might try a transforaminal approach if you were sure that it's that nerve root that's causing the problem. But if the problem is above or below or the transiting nerve root rather than the exiting nerve root, then you'll have a failure of the technique. So my approach is usually for a caudal, and it does for a couple of reasons. It actually helps expand the epidural space. It gives me a roadmap of where my problems might be, and it's a wonderful approach then with an adhesiolysis. So I'm going into an area I've already been if I've done the caudal first. So let's talk about the anatomy just a minute. You have your spinous process and the pedicles, spinous process and pedicles, spinous process, pedicles, and the nerve root coming out underneath the pedicle. And when we look under fluoro, we have spinous process pedicles and nerve root. And when we look at it from the lateral, we see this pedicle and the nerve root, and on the fluoro, we see the pedicle and the nerve root and our target. But when we're looking at a caudal, we need to look at the anatomy of the sacrum. So we have the posterior portions of the sacrum, the sacral cornu, and the sacral hiatus. We also have the sacral foramen, which have both posterior openings and anterior openings. And then we have the sacroiliac joint, which is the connection between the sacrum and the iliac crest. And so under fluoro, we see the smaller posterior openings and the anterior larger openings. And these nerve roots are coming out like the roots of a tree, and they are going out each of the nerve root levels. And that's what we're seeing when we're doing the contrast for a caudal epidural. We have so if we look at this from the lateral view, we see the posterior elements, the anterior elements. We see this fact that the roof ends before you get to the end of the tailbone, and that this is the sacral hiatus and our target. And we have the nerve roots going posteriorly and the nerve roots going anteriorly. We're worrying about the anterior nerve roots right now that make up the sciatic nerve. And so here you see a caudal with the dye going, the posterior elements, the anterior sacrum itself, the nerve roots coming out. One other thing we need to remember is that there is embryologically a median plica. It's sort of like a curtain that hangs down in the middle of the epidural space as a suspension of the dura. And that can make a difference when we're talking about whether or not the medicine is going to go across from the midline from one side to another. For many people, this plica is very fenestrated. It has many holes. But in other people, it can be very, very thick and can prevent the medicine or a catheter or a stimulator from going across. So how do we find the sacral hiatus? Well, there are 4 ways. The most common way we look at is you can feel the sacral cornu, and the sacral hiatus is located between the cornu. So you feel these little 2 bumps and a depression just distal to that in the midline. But when people are heavy or they don't have big cornu, you can't do that. So you always need to have alternative techniques. So a second technique is to make an equilateral triangle. Now this picture shows using 2 hands, but I actually do it with 1 hand. I place my thumb and my middle finger on the posterior superior iliac spines, and then my index finger as an equilateral triangle will point right to the sacral hiatus. And then a third way, fascinating, that works every time, you position your hand over the sacrum, the middle finger goes to the very tip of the coccyx, and the sacral hiatus is usually right over the proximal interpharyngeal joint, or the PIP there, every single time. It's fascinating. And then the 4th way is to be able to look at it under fluoroscopy, and you'll see that little bit of lightening of the bone, because there's less bone there, and you'll see it, the sacral hiatus there. So we found the sacral hiatus, we've done our sterile prep and drape, and now we enter the caudal epidural space. We enter the space and then drop the needle down and advance a small amount. Now, it's key to advance just a small amount because you do have the intrathecal sac that's coming down sometimes as low as S2. And I strongly recommend that before you do a caudal, you look at the MRI and you look to see where the sacral hiatus, where the thecal sac ends. And so then you inject your medicine. And one of the things that you see with this is that all the medicine went to one side and there's nothing going over to the right. And so this is exactly the kind of patient that Dr. Rácz saw in the early 80s, where he would do a caudal and he couldn't get medicine to go to the place where it needed to go. And from that, he actually developed this whole technique, was to address that specific patient. So he developed this wire-bound catheter and then a special needle with a very flat entrance, a very flat bevel, so that you could take this catheter back and forth and be able to use it to manipulate, to hydrodissect, to mechanically dissect. So I think of this as very much like a cardiac catheterization, where you've done the catheterization and now you're going to do the stent to open up the areas. And so here you see the catheter threaded out to the L4 to the L5 nerve root, and then medicine now injected, and you see the medicine going out the L4, the L3, the S1, clearing that whole area up. And so this is the perfect patient, the perfect way. You can see exactly the outline. And this is from my dear friend, Agi Strogitsa. Now, her colleague at Rácz is going to show another one. Again, caudal epidural, you can see these filling defects. There's just no medicine going to the nerve roots, nothing going above S1. And you can see how stuck down this area is, even though there's been no surgery in the area. So she puts more volume in, and the fluid from the volume, the volume from the fluid opens up a good part of this. And you start to see the medicine going out the L5 and the S1 and the S2 nerve roots, the S1 and the L5 nerve roots on the right. But you see this filling defect on the left. And you also see just that median placi that I was talking about, that white line down the center of the epidural space. And so this filling defect is what will then be our problem. So we're going to try and take the catheter. She took the catheter up and out the nerve root. She took it out the S1 nerve root and out the L5 nerve root, and was able to open those areas up. And you see this on the lateral. You can see, however, that there was a filling defect. I'm going to show you again. You see this filling defect in the anterior epidural space, right at the level of the disc, just coming down in this area, and everything else opened up except for this region we had. And so if we go back and look at this again, Dr. Rácz has spent many, many, many years trying to figure out how to get medicine to this area. And he's called this the scarring triangle. And the scarring triangle is a unique triangular space that was identified by measuring about 1.5 cc's on each side. The boundaries are medial to the L5 nerve root, lateral to the S1 nerve root, and the base of the triangle is above the disc at L5 S1. It's a space large enough to accept an average loose disc fragment. This space tends to collect leaky disc material, which is a common result of trauma and surgery and leaking discs. And due to the curvature of the sacrum and the formation of dense scarring, that regular epidural catheters and even spinal endoscopy can't enter this scarred epidural space. So Matsumoto realized that entering from the posterior aspect of the L1 neuroforamen with this new specialized needle that I'm going to show you, and then rotating, you could get the curved tip to get to the get a catheter up into that area, and it's steerable as well. And so this specialized needle, now the RX2 Coude needle, fascinating. It's got the curvature that we've been using, that's hence the Coude. It's got that nice flat bevel. And it has a regular needle stylet that goes with it that makes this a very nice sharp needle going through the tissues. But once you've gotten to where you want to be, you take out the regular stylet and you replace it with another stylet that then passes past the edge of the foramen, of the lumen of the needle. And this soft tip pushes the dura out of the way so that you don't have to worry about cutting the dura. So the flat open tip allows for multiple catheter passes, reduce shearing. You've got hub markings to indicate the direction of the curve, and it's radio opaque, and you've got calibrated depth markers on it. So this is typically indicated for patients with ipsilateral back pain. I'm sorry, guys, I had them waved off for a while. L5 radiculopathy, yeah, the mowers are coming, I apologize. Numbness or dysesthesias along the lateral calf, ankle, or foot, and weakness with dorsiflexion of the foot. And this can be subtle, so you've got to really put your patient on their toes and on their heels. And they'll have, they may have actual visible foot drop, but it may be much more subtle. So how do you do it? You place the patient and prone, and you use the C-arm to align the neural foramen so that you're going to have to do a little bit of an oblique so that the anterior, and a little bit of cephalad tilt, so that the anterior and posterior foramen line up. And then your needle entry point is going to be below where you would normally, where you're going to be entering, so that you're coming in at a very flat angle. And so here you see the needle being placed, comes to the top of the foramen, so that you're touching bone, and then redirected down into the foramen. And on lateral, you see that we've just entered into the epidural space. And here the curve is turned down. And then you put the blunt stylet in, and you can here, and then you rotate it so that so that it's now passing cephalad, it's now turning cephalad, and now you start passing the catheter up to that area. And then using fluid, you can release the scar tissue in that area and use fluid to do both a hydrodissection, to relieve the scarring, rinse out the area of all those chemicals from the leaking disc, and release the nerve root so that it's no longer tethered and no longer causing the dural tug. But very much like I think of when you're trying to get a plastic bag and it's all stuck together, and you rub it to try and get the edges of the plastic bag apart. In the same way, we recommend after these procedures to do a technique called neural flossing. And the idea is to move that nerve root back and forth, just like a piece of dental floss, until you've got the nerve root loosened up. So you do that by bringing your knees, the patient's knees up to their chest, legs up, and then legs out. So with adhesiolysis, we've got multiple approaches. You can do a caudal approach, a transforaminal, transgrade approach. You can do it in the cervical, and then you can do the scarring triangle at S1. It addresses problems that can't be usually addressed by other means, and it provides your patients a safe and effective alternative to surgery or stimulation that actually fixes the problem. Now, I'm going to do just a few seconds of a promo for another course. Obviously, y'all are interested in learning. So Pain School International is setting up an e-learning seminar series. These are 30-minute lectures followed by 30-minute live patient procedures. And so if you go to the Pain School International website, painschoolinternational.com, click over on the right-hand side, and you'll get this menu, and then click on pain courses, and you'll see the e-learning series. And then you'll see that starting in the middle of November, we're going to start having weekly courses, an hour each time, looking at a whole variety of different kinds of RF procedures. So thank you very much. And I think I've got just a little bit of time for questions. Any questions? Are there any questions? So there are a variety of medicines that can be used, and I think they're all going to be discussed at a later time, but I'll just do the laundry list. We use local anesthetic. I use a lot of saline for hydrodissection, steroids for anti-inflammatory medicines, hypertonic saline as a denervating agent for the small unmyelinated nerves, and also as a shrinking some of the edema and also increasing the volume in the epidural space, contributing to the expansion of the fluid, as well as hyaluronidase to try and break up those adhesions by lysing the connections between those adhesive tissues. Well, I think they're both important. It's a little bit like saying, do you need to have you're going to use both. We're working on different mechanisms. And so you've got to do the volume to open the area up, like blowing up a balloon that's all stuck down. You need to be able to lyse the tissues. And then the steroid, I've always been a huge fan of steroids in terms of the best anti-inflammatory medicines that we have. Can you repeat the last part of that question? When doing a transforaminal, there are problems doing what? I'm sorry? Well, I think, again, this will be addressed by some other of your lecturers, but yeah, problems in advancing the catheter cephalad. I think the issue is going to be if that's where your adhesions are. Dr. Rácz is very adamant that you really can't do these as midline procedures because of the risk of subdural. And so you really have to be in that far lateral area. If you're doing it as a transforaminal, I actually find the transgrade easier to do. So I come from the opposite direction and then thread up because it's sometimes hard to make that very sharp right-hand curve. But I think and then putting a curve on the end of the catheter will help. A sharp bend on the end of the catheter will help. And I put a lot of fluid in before I try and put the catheter in to give me as much open area to start with as possible. So I look very carefully at my MRIs preoperatively, and I probably should have put that slide in as well. On the sagittal views, the T2 sagittal views, I actually look specifically at the end of the thecal sac. And I've noticed things like Tarloff cysts, like low-lying thecal sacs. And so it helps me plan so that I know that I can't go up to S3. I have to stay back at S4, that I need to put my contrast in early before I start to advance, so that I make sure, and then I need to go laterally sooner because of the intrathecal sac. But your MRI is going to tell you. You've got to look at your own MRIs. Do not rely on what the radiologist says. I'm sorry? How much saline volume can you use? 1 second. There is, the original caudal epidurals were done with 100 cc's of fluid, and that was done in 1901. However, one of the things that I have found is as I open up that epidural space, often the patients will suddenly have a headache or a pressure sensation. And I think you're suddenly getting fluid up to a higher level. And there have been, with spinal endoscopies done under general anesthetic or deep sedation, there have been some concerns with volume and pressure in even the optic nerves, but they're using huge volumes of fluid, using the fluid to distend the epidural space like you would do with laparoscopy. So I try and keep it, I'm rarely doing more than about 20 cc's of fluid, but I'm fairly cautious because I'm usually doing mine in the office without sedation. But I think it's important to when your patient starts complaining of increased pain, and I have them talking to me all the time, it's a compliance matter. How much air can you put in the lungs? Well, it depends on how stiff the lungs are. And so when this epidural space is scarred down, you can only use small amounts of medicine. And when the epidural space is more open, you can use larger amounts. Well, your first key is your contrast pattern. So it's going to be critical to look at contrast patterns. Is this medicine going out is the dye going out the nerve root, or is it sequestered in the center? Test doses are important, and that's why Dr. Rácz teaches that you don't do large doses of local anesthetic. You certainly don't do the hypertonic saline until and unless you've waited 30 minutes to make sure that there's not going to be a subdural. That's the harder of the two to identify. There can be, as you're peeling apart the layers peeling the dura off of the anterior or posterior ligaments, you can tear the dura so that you can get some subarachnoid. So I always do a test dose first. I put a small dose of local anesthetic in first, and then I'm doing other things, and then I put a little more. So I'm always doing my local in divided doses. I'm always watching on the lateral to see how the dye is spreading. So if I put a small dose of dye in and it's spreading a long distance, remember the subdural space is much smaller than the epidural space, so small volumes will travel much more. And then if you put in dye and you don't see it going at all, then that needs to be a concern that you're intrathecal, because the dye gets diluted in the intrathecal space so quickly. For the question was the catheter, can the catheter tear the dura? And absolutely, these are stiff catheters, relatively stiff catheters, and they can pierce the dura or the subdural, through the dura into the subdural space or into the intrathecal space. And so it is critical to always be aware throughout the whole procedure that even though you were happily in the epidural space, you could have all of a sudden developed a subdural or an intrathecal placement of the catheter. So really important to constantly be looking at contrast patterns, constantly adding more contrast, constantly thinking about both subdural and intrathecal as potential occurrences while you're doing the procedure and afterwards. Okay. All right. Thanks. Bye-bye.
Every time, no matter who is producing the product. It is all followed by SOPs, IHRs, QAPs.
We do take quality very seriously here at Epimed, and right down to the 100,000th of an inch. If it's out of spec, it's out of spec. There is extreme focus on quality and maintaining a high quality standard on all products manufactured by Epimed.
One of the products that has been very useful for us is the blunt needles, specifically transforaminal needles. The blunt needles has been a very good tool for us, specifically for those patients that are needing this transforaminal single shot block, and like they're having a pinched nerve and things like that. That has been a very useful. And until now, we have a very good experience. No injuries, not like damage. Maybe like it's so natural that if it's so it's had a lot of inflammation, this root, maybe they will have like a paresthesia or something, but no damage because of the blunt tip. And it's very good. All the procedures that goes very near a nerve, it's of course you rather to put a blunt needle instead of a sharp needle. And if you're going to be so close to a nerve like a root, it's more convenient to have a blunt needle. And it's in our case we're using it mostly in transforaminal.
My name is Lauren Stastny, and I'm the clinical sales consultant for Epimed out of Birmingham, Alabama. Did you know that Epimed has over 15 different epidural catheters to choose from for site-specific epidural injections? They do. The catheter that I would like to tell you about today is the BreviCath. It's Epimed's workhorse catheter used for lumbar site-specific injections or the lysis of adhesions. The BreviCath is 19 gauge and 14 inches in length, and the catheter body is heavy duty, but has a soft atraumatic distal tip design. The surgical grade spring wound catheter makes for great durability and ease of placement. The stylet helps ensure precise directional control when placing the catheter with a 1-to-1 torque ratio. However, if you need a catheter designed for situations where your catheter placement is challenged by your patient's epidural scarring, adhesions, or hardware, Epimed has the BreviXL. The XL stands for extra long stylet, which allows for a firm distal tip of the catheter. The Brevi XL is also available in a 19 gauge and 14-inch length. Whenever you need a site-specific catheter for site-specific injections, remember Epimed has all of your catheter needs for lumbar, thoracic, and cervical injections. We are here for you to help minimize risk every procedure, every time.
My department is involved to make sure that we build quality into the product.
So the product is produced the same time, every time, no matter who is producing the product. It is all followed by SOPs, IHRs, QAPs.
We do take quality very seriously here at Epimed, and right down to the 100,000th of an inch. If it's out of spec, it's out of spec. There is extreme focus on quality and maintaining a high quality standard on all products manufactured by Epimed.
Most doctors have placed needles in the cervical epidural space, and here we are picking on T1, T2. A straight needle electrode placement is going to be continuation of the shaft of the needle, and that means you overshoot. When you are placing a spinal cord stimulating electrode, you want to be near midline, and what you're looking at is we are going in a little bit short of midline, and when you get to the edge of the lamina, you start looking, because there's no real good way of telling depth. You have to be heading to the interspace. And then, like here, the angle is fairly steep, and there's no good way of seeing the needle and not keeping your hand out of the X-ray beam. So when you have a paramedian approach, you have more chance of rotating the C-arm more carefully. You notice several things here, that you only see the needle tip. In other words, I was listening to my own advice. I made the C-arm rotate cephalad and placed the guide wire to be sure that in this patient has failed neck surgery syndrome, that I can get an electrode up. And when you look at the guide wire and now focus on the tip of the needle and look at the tip of the needle, the working part of the lumen is the back hub of the needle. There's a considerable length of the needle is sticking out. So if you try to direct the guide wire or the electrode, you would be slashing at the dura with the tip of the needle. So that's one of the problems with the TUI type spinal cord stimulating needles. You can see the principle I mentioned, that when you go close to midline, the electrode tends to overshoot. Secondly, that you need more cephalad rotation than is comfortable, because the left TUI type needle is fully visible, so you would be x-raying your hand. The right RX2 now is getting to the edge of the lamina, and it doesn't really matter whether it's totally midline, because we can rotate where the electrode will go. So now we'll rotate down and go into lateral view. The no headrest, pillow under the chest, drops the shoulder out of the view, and we can go right down to the straight line to use the loss of resistance technique, curving down with a flat needle tip. You can see that entry of the electrode, we were able to reposition more to the left with the TUI type Medtronic needle, and the RX2 needle, we just rotated the tip, And the point that the needle tip is ready to cut with the needle on the left, and the electrode is coming out through the tip of the needle, pushing the dura away. So far I'm not aware of any cuts from rotation either of the needle with the electrode in place or with the second stylet, or in neuroplasties when we have the patient rotate with the catheter in place or with the second stylet in place, the removal, lessening of the danger of cutting the dura is very much a reality.
Hello and welcome back. Thank you so much. I hope that you guys are enjoying the speakers that we have. A big thank you to Dr. Trescot, who talked to us about anatomy and physical exam. Next up, we have Dr. Rácz, but before we get to that, I want to share a little bit of information about the screen and what information you're seeing. So if you have questions, wish to respond, talk to any of our reps, you know what all the buttons are. So I'm sure a lot of you have figured out on the right-hand side is the chat box. Everyone can see what you're chatting. So if you have any questions that you would like to share with Dr. Rácz in this next upcoming section, please write your questions. We will be having a few individuals who will run in from time to time and make sure that Dr. Rácz is clarifying or answering any questions that you have. If you have a question about a specific product, because he will mention a couple of different products, there is a red box that is below, and in that you can talk privately or leave a message with someone from Epimed who will answer those questions for you. Or if you want a little bit more clarification, want to speak with one of our distributors or sales reps, you're welcome to head over into the Zoom room. And you can have a private chat. We'll let you in from time to time. There's it sets up a waiting room, so just be patient and we will be right with you. Also, I expect that Dr. Rácz will mention several different articles and studies. Most of those studies and those articles that he will discuss today are located at the lower end of the screen. So feel free to scroll down there. Many of those were sent out to you in advance. If you didn't sign up until the last minute, it's okay. All that information is right there at your fingertips. Once again, we have Dr. Rácz. He is going to be up for about an hour and 15 minutes. Following that, he will be talking about caudal lysis. Following Dr. Rácz is Dr. Mishra. He's going to be in discussing transforaminal lysis. And then we will come back to Dr. Rácz and he will do cervical before we break for lunch. I know that lunch may be dinner or bedtime for some of you, but we will have a break. For our U.S. participants, please note that over lunch we have a special program in our Zoom room for you discussing reimbursements. In the afternoon, we will come back and Dr. Rácz will be back in the lab. We will talk about S1, the scarring triangle. Dr. Fox, after that, will be meeting with us talking about lysis in your private practice. And we will conclude with a roundtable. Because I know that not everyone, this time works best for everyone, please note that we are recording all of these sessions and they will be available for you to view by tomorrow, probably about 30 minutes after we conclude. This information will be up. It will stay up until the end of October. So if you wish to revisit, review, or come back and see a section that you weren't able to view, please note that that information is going to be up there for you. So next, we've got Dr. Rácz. I am sure most of you know Dr. Rácz. Many of you, I'm sure, have met with him. Just a little bit of information about Dr. Rácz. He was the co-founder of the World Institute of Pain. He is the director emeritus of ACIP. He is the professor emeritus at Texas Tech University Health Science Center. He is the chairman emeritus of the Department of Anesthesiology and co-director of Pain Services. He has written many chapters. He has been the expert witness on multiple cases. He has taught all around the world, and it is such a pleasure to have him here today and to meet with all of you. And even though we all can't be together in the lab, we are so honored and happy to be able to bring him to you in this virtual event. So up next is Dr. Rácz.
Demonstrating caudal epidurals. And to find where you get in is you look at your knuckles and feel your, between first and second knuckle here, feel there's a sacral hiatus-like structure. It's not good enough to feel just one. You've got to roll it, and I'm feeling it, and I feel the left and right sacral cornua. The access to the caudal epidural space is, if it's a one-day procedure or a single setting, you can come straight close to it, a little bit below, and put it in, and you can feel when you're in. Picture. I am curving the tip of the needle down. And if you take a look at the tip of the needle, it has a nice curve and a wide open tip. This is a wide, completely 360 degree, complete opening. There's no bend to the tip. This is the Irax coude. Coude means curved elbow in French. And we just took the name from the coude foley and double coude, and found it describes exactly. Now the stylet goes to the very tip, and when you move the needle in the epidural space, you have a second stylet that has a two-borst fitting. That means you can lock it in. And when you look at it now, it projects beyond the tip about 1 millimeter. And it makes the tip non-cutting. Because when you rotate a needle or you try to help, that can lacerate the dura, lacerate veins, any structure comes close to it. Now, one of the tricks I have to say to you now, that when you put the second stylet in, and if you go like a wild man and push on it, it can, the tip of the needle very, very rarely actually can jam the second stylet, so that when you try to undo the second stylet, you cannot get it out. And if you are really forcing it, as soon as you run any problem, you take the needle out together with the stylet. And otherwise, you may actually try to pull it out, and suddenly it gives, and then you go through the dura. You know, it's a no-no. Any resistance to anything you do, you take everything out, and you start again. You know, it's the old Viet Cong motto: run today and live to fight another day. I have never seen any single case where there would be a medical legal malpractice suit for canceling a case. So this is one of the very rare. Now, and ultimately you cause the problem, because this is a plastic to plastic, and if you jam it too hard and you cannot undo it, you just take it out and start again. So this is something, a bit of safety concern. Now, you may never see it. So we have I felt for the sacral hiatus, and I went really close underneath, close to the hiatus. I only do this after double prepping and waiting to dry in between, so that there's absolute sterility anywhere you go. Otherwise, I go at 2 inches down, 1 inch off midline, up the gluteal mound, and then basically I add 2 inches of distance under the skin for the catheter to be tunneling away the entry point. But here it's a simple thing. And now we are going to put the second stylet for the sake of safety, because I do not like to move the needle, like rotating anytime in the epidural space. With the second stylet, it's very safe. I never ever had a problem with it. And now, if you take a look, so we're heading a little bit to the right side, and I took the stylet out a little bit too soon. Now let's assume we go to the right side, or we can go to the left side, and let's go to the left side. So we just turn 90 degrees, and you can see the tip of the needle is pointing to the left side, and I can influence it by pushing it. Picture. Lesson number 1, do not go way over to the side, because you hit the side wall of the sacrum and it bounces, the catheter will bounce off and you lose control. So you don't go way over, you don't go in the midline. And now we take the Brevi XL. What that means, it is a short catheter. For the 3 daily injections, I like to have a 24-inch, which is longer. And in order to direct a catheter, you cannot direct a straight catheter. You have to put a bend in it. And I, having trained literally thousands of people, and one of the most difficult things to do is to teach them how to put a 1-inch long bend. Because I realized that the simplest thing is to put a mark in. The longer one is the 1 inch, and the other one is for the cervical and thoracic. There is not enough room for a 1-inch bend. So you put your mark the marks are part of the catheter. So now I can navigate when I hit an obstruction, and you see it because the catheter would buckle, and when you have no resistance, there's no buckling. So now we're going to go to the left side. Picture. And see, at this point I can push the catheter a little bit over to try to influence. Flora. Flora continues. Let's see, it rotated on me, so I'm going to rotate back. Follow me up. And we're going to go into the left L5 nerve root. And voila, there we are. Now, if I want to go higher, I haven't tried this grab, Flora. Now I rotate, avoid the trap of going into the left, just navigate it a little bit, and now I'm going into the, and as soon as you see the catheter sloping down, that means it's going in the ventral epidural space. If the bend goes towards the middle, it's going posterior. So let's have a look in the lateral view, and our target is always ventral lateral. So that should be the L4 nerve root. Go up higher, and there you see the catheter is exactly where we want to be. Ventral epidural, the nerve root comes out just a little bit above the disc, so it's just below the L4 nerve root, and here was the sort of crunched L5, and we were there before, and now we are at the L4 nerve root. Now if you say I want to be at L5, so let's see if we can change that. Okay, AP, front to back. And I'm going to pull it out. Flora. Okay. Flora continues. And just a little bit, I want to go a little bit closer. You see, it flops on me a bit. And when you, the time you rotate the catheter is when so here I'm trying to rotate the catheter. I feel that the wall of the plastic was a bit caught. And now we are going up. And we are in the L5 nerve root. Okay, just look in the lateral view. You may notice I'm wearing gloves. These are leaded gloves because back in '86, just lower it a little bit. And here we are, ventral epidural space, lateral. And you can see that's about as good a position as you want, and I can possibly push it in a little bit more, but you don't want to be outside. We're in a ventral epidural space and going out to the L5 nerve. There's a little, you see there's a bit of slippage there, but we're at the top of the sacrum, and L5 is slipping forward, but that's about as good as you can do with it. And now we inject 5 cc's. Actually, in the caudal epidural, I inject 10 cc's of Omnipec 240, and followed by 10 cc's of hyaluronidase, and then I inject 10 cc's of 0.2% ropivacaine or bupivacaine. I tend to use more ropivacaine than bupivacaine, but it's a concentration issue. The 0.2% versus 0.25% bupivacaine. And I usually do just use 1 dose of steroid. Now go back to the AP view. Let me show what a lot of the surgeons that don't want to be bothered by paying attention to little details, and I have done like 158 procedures on patients in South Korea, but you know, so I know when it's not critical. I work with spine surgeons and neurosurgeons, but most of the people are anesthesiologists and some physiatrists that can learn and really do become very, very good at the procedure. And they do incredibly large numbers and getting phenomenal long-term results. Like Ludger Gödelsmeyer, the German, the best study ever. And for what we are doing, and anyway, the weakness of the surgeons that they just think or just have to be up. Picture, please, come down, show me the, yeah, okay. When they just go straight up, Flora, let me just change this thing, show you again how we go in and use a different needle. So again, feel the sacral hiatus, and I'm in picture. And if I was one of these guys, and when I went back, now this is the longer one, the 24 inches, but let me look for another catheter here. The Brevi. Could I have a Brevi catheter? Although I can demonstrate what I want to do what I want you to see what not to do is to put the catheter straight in the middle picture, and if we get it a little bit to the, and this is the formula for disaster. Now that's what you don't want to do, because now you're running into the lower end of the dura and the nerve roots are coming out. And when you go in with a stylated straight catheter, it may be just stiff enough that as the catheter gets to the base, the armpit of a nerve root, that it just pops in subdural. And your biggest problem, that this is why I delay and slow down with the injection and wait at least 20 minutes before we think about putting in hypertonic saline. Because when you are subdural with 0.2% ropivacaine or 0.25% bupivacaine, it takes about 14 minutes to get a motor block. That's the beauty of bupivacaine. It separates the weakness and a motor block, but if here you get into subdural space and then you inject the ropivacaine or bupivacaine, the patient may look fine, like I've been expert witness in a bunch of these cases. And what happens is that when you inject, and if the patient is heavily sedated, they may not say anything, but do not use heavy sedation, please. A little midazolam, a little fentanyl is plenty of sedation. Like the elderly doesn't take much sedation, just little kindness, but you want to know when you are developing a motor block, but it doesn't come for 14 to 15 minutes. And by that time you are on to the next case. And then the patient is doing fine, in fact is getting ready, his pain is gone, is happy, and everybody leaves, and within the next couple of minutes the patient suddenly just stops breathing, it goes all the way up, a long way, and they cannot even call for help, and then you can have a respiratory arrest. Or if you put in the hypertonic too rapidly and don't waste 20 minutes, because you must not have a motor block before you put hypertonic in. And the pain-free hypertonic now, we figured it out eventually. It took almost 30 years to understand. But now we put in 1.5 cc for the caudal, 1% lidocaine as a bolus, and then we dilute from a highly concentrated hypertonic, a corrosive mixture, because it comes in an ampule, and take 4 cc's of 23.4% and 6 cc's of 1% lidocaine to dilute it, and that will give you about a 10% sodium chloride mixture with a bit of lidocaine. And it's not enough to stop the pain. But if you do the bolus about a minute or a minute and a half or thereabouts before, that pushes the injected 10% with a 0.6% lidocaine mixture that will be now completely pain-free. So the difference is that we ended up with a phenomenally good, cost-effective way of doing the observation, because with the 0.25% first injection, it takes about 4 hours before you can be sure that the leg doesn't give out. And I've seen the early days, the patient is ready to go home, he's happy, and gets out of bed, and the knees buckle and hits the kneecaps. And it's not very good. But with the new system of not using a 0.25% bupivacaine, but using a 1/8% bupivacaine, these patients now are able to be discharged from the observation period in the recovery room and walk to the bathroom and void. And now that's what we do on the second and the third injection. The gap between the first and second is 4 hours, and that seems to work. And then they get up before we let them go to stay in a motel, so we don't admit them anymore. We started out almost 30 years ago admitting these patients in the hospital and be in there for 3 days because we did it once a day. But now we do the first injection in the morning, the second 4 hours later, and then the second injection is 1/8% bupivacaine, because we know at this point that there is no subdural injection. And you please avoid in the midline, and that every case I've seen a disaster of, which is from high pressure from the hypertonic saline, has the issue of hydrostatic pressure is not the issue. It's the osmotic pressure that is important. It draws fluid in, and 10 cc, 10% sodium chloride shall become 0.9% sodium chloride. In other words, it will dilute from 10% to 0.9% by expanding 11 times bigger volumes. It's going to be 110 cc. And that can put pressure on the blood supply of the cord, the nerves, the conus, and you can have bowel bladder dysfunction. Now, if you see that, you look in the lateral view, just look in the lateral view, you will see like a sausage. The contrast is going to be surrounding and a clear space in the middle. I just take a needle and put it interlaminar, and I think this is a beautiful, beautiful picture, but I'll make the point. But first, you can go in, just move a little bit higher. You go interlaminar into the contrast part within the subdural space, because as you fill up the space, you can see where the high pressure is compressing the blood supply, and the patient will tell you, I have pain going down both legs. That's the key. And so I just stick a needle in, and aspirate. The beauty of the subdural space aspiration is you can aspirate, and I get 13 cc. I only had one of these cases myself, but we published it, and I had one of my former fellows, he did the same, and the patients recover immediately, but you got to get the aspiration and got to get the fluid out of the subdural space. That's hugely important. Now, if you move down, so in other words, let me just go back again. In other words, if I was to come in interlaminar here, I would come down to about there into the dark contrast area. That we don't have it here because this is not subdural, and aspirate the fluid out, and the pain immediately goes. Now, just move down a little bit towards where the feet would be. Picture. If you see what happens, we are starting out, and look at the curvature of the sacrum. And this is why you cannot move up a little bit. You cannot get the catheter into the patients with a scarring area. Come a bit higher. And you cannot get it down here. So that's where the target is, in the ventral epidural space. But because of the curvature, move down a bit. Curvature is in the sacrum. That curvature sends the catheter posteriorly. I mean, yes, posteriorly. And your target is, and even if I rotate the needle down, picture, you see that's the consequence of the curvature. And when you have dense scarring, you cannot get to it unless we do the trans S1, move up higher, more higher, and lower it a bit. Higher and lower it. Too much white showing. You see, this is where the target is. It's right there. You see, there's a bit of a mashed L5 body, but that's where the scarring triangle is. So this person, the cadaver, must have had tremendous pain coming from that compressed area. But these are the cases that you have to deal with, and you have to understand some of the pitfalls and the traps. Now, our mission is not to do the trans S1 yet. Well, we'll get to it later today. But when I think about how much more we have learned, like almost 26 years ago, we presented a series of 100 patients, 50. This was in IASP World Congress in Paris, and we had 50 patients where we used hyaluronidase, 50 patients where we did not. Looking back, failed back surgery, just bulging disc, loose fragments. So the back surgery was the issue. and the degenerative disc disease. And we found that, this is like 30 years ago, that hyaluronidase was incredibly effective. And we didn't know how effective because nobody's ever looked at it up to that point. But the outright failure rate at the end of 12 months was 18%. And the group, the 50 patients where we used 1,500 units of hyaluronidase, went to 6%. That was the effect of using hyaluronidase in just watching what we've done so far. When you have multi-level disease like spinal stenosis, it totally changes the picture. Like this patient, you would have scarring in different places, so we have to come in with a second catheter transforaminally and put it in mid-canal, and it dramatically lowers the patient's pain. So you have to go where the ventral epidural space is not freed up. So you have to look at the lateral view. So not looking at a lateral view is terribly bad. Now the contraindications would be if you have arachnoiditis in the novice's hands. But if I see any arachnoiditis, I will be ever so ginger, because arachnoiditis usually following surgery or contrast related or inflammation or infection. And if you dissect into the subdural space, then you get loculation. If you have loculation because of scar formation, you can get movement of the fluid by flexion, rotation. And there is a nice description of in pain pain practice, collegial communications, look it up. And it's an actual 12 months follow-up where loculation and subdural injection put pressure on the cord, and the patient had weakness of the foot and bilateral pain, and by flexing, rotating on the way from the operating room where the doctor called me, and I asked him, do you have any pictures? And you will see the story unfold in front of you with a 12 months follow-up where the patient did great by the use of flexion, rotation to distribute the loculation pressure over a longer distance. And the patient's foot weakness that was developing, and one-sided weakness, was reversed before we had to do anything. At MRI, and the consultants couldn't recommend anything else other than give a bit more steroids, but I already gave steroids in the injection. So the other rare contraindication, I would say, having been in almost over 350 cases, almost 400 medical legal cases, where just the loss of resistance fluid to get into the epidural space in a patient had a syrinx. Stay out of syrinx formations. Do not go anywhere near that patient. That you will not make dramatic improvements. Well, this was a spinal cord stimulator case, and And a patient developed cord injury just from the loss of resistance fluid. So be very leery, very careful. Well, I get in, but you know, you develop after a few thousand cases, develop a sixth sense as to what you can and cannot do. And so far, I haven't really paralyzed. The first series we published in the Techniques of Neurolysis book was the first 100-some cases, and I had one of my fellows who only sin he had, he happened to stand next to me, and so I said, Jerry, this was Jerry Hollybeck, look up 100-some cases of this procedure, and we developed a name for it. We called it lysis of adhesions. We didn't even have a name for it, you know. But this is what we are learning new things. We are learning brand new things almost daily. And you'll be hearing later dural flossing, and I'll show a little clip on the movement of the dura that is mind-blowing. But when I see it, I get mesmerized, and this is so beautiful. There is simply nothing better, longer lasting than neuroplasty. Recent study on systematic review studying long-term evidence, and found that only two procedures that are around you have long-lasting studies, and that is neuroplasty and neuromodulation, except the evidence is better for neuroplasty. 70, 80 some papers have been written, and nothing significantly relevant. So my head down to you for spending time, and I think it's, if you pay attention to this, don't hit the side, and make sure you know where the needle is pointing, and just best of luck. And I'm impressed that we have this level of interest, and thank you very much.
Great. We're going to have some questions asked from the viewers, and the first question is, this is coming up. What would you recommend for the hyaluronidase dosage? In some areas, they only have available 150 unit ampules.
Yeah.
And how many 150 unit ampules would be enough on a patient before injecting the steroid?
This is very fascinating, excellent question. The reason why we put in 1,500 milligrams, which was an animal extract, the 150 units is a recombinant human synthetic hyaluronidase. And the effect of hyaluronidase is spreading, and for example, when I do a transforaminal hyaluronidase, I mix up 10 cc's, and remember I mentioned inject 5 cc's. It's basically half of 150 units. And 150 units and 1,500 units has the same effect. It inhibits neutrophil infiltration, and it has no negative effect whatsoever. And it's 2 papers and lots of clinical experience, and we do not need many ampules of 150. It would price itself out. The study in a rat model pouch on inhibition of neutrophil infiltration, and neutrophil infiltration is the first step in inflammatory edema. So that when you use hyaluronidase, the chances of you having a steroid flare-up pain in the first day or two just disappears. It doesn't happen. It inhibits the inflammatory changes. And 150 units, I make up 10 cc's and inject half of it. If I do 2 level, 5 is the 75, and we tend not to use the animal extract, although the FDA doesn't like it to say one versus the other, but the purity of the animal extract is so many more proteins there, but it's never been measured to be of any difference. But 150 units is good enough for 2 5 cc transforaminal injections, or I just use 150 units in the caudal 10 cc, and the volume changes. Now, the only difference in transforaminals is if you do a small volume along the ISIS lines, it works on radiculopathy. And when you inject a bigger volume or go into the epidural space, it works on radiculopathy and back pain. 2 papers from Korea. That's the sequence to my visiting, and why are they doing so many papers? Because they've done thousands of cases, large numbers. One hospital I went to visit 2 years later, in the intervening 2 years, they did 10,000 cases, over 10,000 cases. So it works because the net effect of surgery is better, and when pain comes back, it comes back on the other side where you work, or at a different level where you work. So you have to chase after the diagnosis where the level of the pain is. But anyway, that's how I run it is story. And there's only one negative. There was a paper from Canada, and somehow Steve Cohen added a bit to it, and he says hyaluronidase doesn't do anything except add to complications and costs, and that's total nonsense, because they did not study complications and they did not study costs, and he has absolutely no evidence. That's an opinion, unfounded, unsupported by any evidence. But the evidence is that it does help neutrophil infiltration, it does help spreading, and a bigger volume does help back pain. And back pain, I believe, is a function from the dura being stuck to the posterior longitudinal ligament.
We have time for one more question. This is from Dr. Camille. There have been a lot of discussion on using dextrose, especially dextrose 5% for neuropathic pain. What is your opinion on using dextrose 5% in epidurolysis?
Well, before we went to the increased concentration of injection, I reviewed all the available literature. So I know a bit about effect of concentration. And it's interesting, but increased osmolality and increased concentration, it interferes with compound action potential, nerve conduction. And it becomes like a local anesthetic. And the optimum dose was 5% of any substance. But the evidence we have is with sodium chloride. It's millions of cases. And would I use 5% glucose? Hell no. Because I realize the phenomenal effect of hypertonic saline and realize the safety. The issue is loculation afterwards, whether glucose or whether any concentration. We learned a great deal and we know what is safe, and we haven't learned all the issues with the sugars in the epidural space. But osmolality, it will be volume expander, and if you expand the volumes, your consequence of the normal osmolality, and eventually everything boils down to 0.9%. I mean, even in glucose, it's around about 100. 5% is going to be 5 times your normal. So the expansion of the volume expansion will be the same principle. But no, I would not encourage anybody to use glucose because we don't know enough about it. And we have millions of cases, literally, and 70, 80 papers, excellent studies. The best study that puts hypertonic saline into the realm of being the best human study, the prospective randomized placebo control, where they compared the injection site being under the skin versus epidural, and did a 10-year follow-up on it. And 10 years later, the effect is still there. It's still positive. So that's as good as my paper and the lectures of the 10-year follow-up. So I would say yes for hypertonic, no for, and any pressure change, any pain is a subdural injection. And if you inject hypertonic, remember, unknown concentration of hypertonic sodium chloride was first introduced by Professor Hitchcock, professor of neurosurgery, and was published in Lancet in 1967. So it's a long, long knowledge, epidural, subdural, subarachnoid. And it's not a neurolytic, it's a local anesthetic-like action. Thank you very much.
I'm from Campinas, Brazil, and I'd like to talk to you today about discogenic low back pain and about a conservative treatment for discogenic low back pain that I'm very excited that is the pulsed radiofrequency on the dorsal root ganglion of L2. Discogenic pain is the most common cause of low back pain. Around 40% of the patients with low back pain, they have discogenic pain. Everything that will increase the pressure in the disc will decrease its nutrition, like obesity, bad posture, or exercise trauma, and this will lead that the disc is one of the first structures in our body that starts its degenerating process. I think the pulsed radiofrequency on the DRG of L2 is a very effective and safe procedure for the patients that we suspect of discogenic low back pain.
The use of fluoroscopy is very important for interventional pain management. It improves the safety of a procedure performed, and the precision cannot be achieved without the use of fluoroscopy. Unfortunately, most physicians who are trained in interventional pain are not trained in proper use of fluoroscopic equipment, and this leads to excessive radiation, not only to the physician but also to the patient and also the supporting staff. It is important for the physician to know how to properly use the radiation protection equipment, how to minimize the radiation by using each and every available modality to reduce the radiation coming out of the fluoroscopic machine. The protection that can be achieved properly without compromising the efficacy of fluoroscopic equipment is the use of low-dose radiation, which is available in most modern equipment, use of collimation, which reduces the exposure that comes out of the radiation tube, and also to use protective equipment and protective aprons or eyeglasses. It is very important to use radiation protection gloves. Although these gloves don't completely block the radiation, they attenuate the amount of radiation absorbed by the hands. To minimize the exposure to radiation, one has to remember especially three different terms. The time of exposure, which means whether to use continuous radiation or pulsed mode, or intermittent dosage, the distance away from the tube that delivers the X-ray radiation, and also the amount of exposure, which is the strength of the radiation is emitted by the tube. By taking proper precautions, a physician can perform proper interventional pain management procedure without unduly exposing himself to radiation and also endangering the patient's life by exposing them to excessive radiation.
The concept of positioning, the concept of sedation, and the concept of not going at the dura with a sharp needle, and certainly don't use a windshield wiper position with a sharp needle at the dura. Because when you are so preoccupied getting the electrode, you tend to forget what the other hand is doing. So these are issues that are important. The same principles apply to the transforaminal electrode and catheter placement. And you will be doing more and more of the transforaminal electrode and needles, because that's where the evidence is taking us. So it's an evidence-driven medicine. Sometimes it takes many years to generate the evidence, but we're getting more and more evidence. So evidence is the name of the game, and clinical experience, until you get the evidence and confirm it, is very much part of our life. So we have evidence, we have clinical experience, and common sense. So just make your right choices. Good luck.
The fruit of the labor of the WIP organization has certainly proven to be the FIPP certification.
What an honor to be recognized on an international level as board certified in your specialty. WIP is a unique organization. It's the only organization of its kind that will allow you to exchange ideas with physicians in other parts of the world, while at the same time maintaining and achieving the distinction of a certification through the FIPP examination process. When we see physicians who hold the title FIPP, we immediately understand a lot more about that physician. The title has a meaning to it. It has a credibility to it. And I think for those people who are very serious about their careers as interventional pain physicians, the FIPP title, which is obviously not compulsory or obligatory, it remains the ultimate honor and distinction for your craft and your quest for being the best you can be as a pain specialist. The lectures and workshops that have been conducted by WIP over the years have always stressed safety first. The outcomes are evidence-based as well as evidence we obtain from our own experiences. That's how we exchange ideas. That's how ideas are started and brought to fruition. But safety is always paramount. The FIPP certification is an exam that will clearly identify you as having met the qualifications of understanding how important safety is as a pain specialist. One of the beautiful aspects of FIPP as an international organization is that we're constantly expanding and reaching different parts of the world that we never thought we would be in. I had a couple of amazing trips to India, one with the late Prithvi Raj, may he rest in peace. And those are memories and experiences that will be forever. I think as an international organization, we offer so much for people to learn, exchange ideas, and to grow by visiting remote parts of the world where people can benefit from what we do as pain specialists, people who are not fortunate enough to have the care that we can get in many other places. And I think that we're in the process of doing work that will allow us to reach physicians in these remote areas of the world so that we don't necessarily treat those patients, but teach and educate how those physicians in those areas can do that.
All good. Hi, I just want to welcome back and pop in and give a big shout out to our crew that's putting this all together for us. It's being done by our PainCast filming group. If you are not familiar with PainCast, you'll definitely want to check out paincast.com. It is the digital source for all education and communication for pain physicians. Earlier this year, we did, there was a rollout of PainCast Pro. So if you've used PainCast in the past and you're just coming back to take a look at it, would love you to take a look at our PainCast Pro. It is a subscription where you can either choose to pay monthly or you can pay annually. It's not a large fee, and it's really amazing for everything you get. So you'll get everything from documentaries, you'll get videos in procedures similar to like what we're doing today, articles. There's even a forum where you can talk to other physicians around the world. So it is an excellent source. And as you can see, they work very hard to produce wonderful material. And once again, paincast.com. Go check them out. If you're not already a member, sign up today.
Paincast has been very helpful to promote and provide videos and data and bring a lot of people from around the world together.
Donde los colegas que todavía no tienen una formación completa y quieren que comenzar a profundizar, profesores con mucha experiencia, ya certificados, pueden contarles en una forma sencilla cómo hacen los procedimientos.
Many countries around the world don't have any sort of formal pain training. Just because you don't have a pain fellowship in your country doesn't mean that people don't have pain. So a website like Paincast allows pain physicians to really learn from each other. And certainly it's possible to go and look something up on Wikipedia or Google, but you don't really know what those sources are.
What is fake news, what's actually trusted news, you don't know. In this stage, you really need trusted sources. And I believe Paincast is a trusted source.
We are at a phase with pain management where a lot of the countries, I would say majority of the countries, do not have any access to formal pain fellowship training. They don't even have access to actually watch other physicians and kind of learn the tricks. So having an online, not to mention freely accessible education tool is a fantastic support.
As an academician over the last 18 and a half years, whenever I needed information, in the beginning I'd have to go to the library, I would do a Google search, or I would go to our own website. And that takes time. A busy physician needs something that they can get at a moment's notice, and Paincast serves that role.
I have strong belief that the resources that are embedded in the Paincast website will be of tremendous use to any aspiring pain doctors.
Aunque no estemos cara a cara o presentes ante un tipo tradicional de enseñanza, la posibilidad de ver videos y de ver películas y de ver, entender los comentarios es una gran opción de aprendizaje y de enseñanza.
We as physicians and healthcare providers need to always remember that we are students, that we should continue to learn for our entire careers, and that if we get set in our ways and don't learn, well, then we're not doing what's best for our patients.
Paincast will be a website really for pain physicians and monitored by pain physicians.
Que é um site de educação na área de dor para os médicos de dor, para que vocês realmente possam ver a quantidade de informação interessante que tem para que vocês possam se atualizar na área da terapia intervencionista da dor.
It's a great website, a great online tool to get new ideas, and that's why I use Paincast.
Tracy here again. I just want to share with you information that will occur after the Rácz Lab. So first off, if you are viewing this live and you need to leave because it's going to be quite late or something else is going on, or you want to just revisit this information, please note that about 30 minutes after the conclusion of this program, we will have this information up on video. So you can come back, watch it at your leisure. This information will be up through the end of October. So once again, come back at any time. Not only are these videos up there, but all of the supplemental information that is listed below. So if you're looking for any of the information, I know Dr. Rácz had mentioned his pain-free and the medicine measurements. Please go below. That information is right there for you. We want to keep your education continuing. So after the Rácz Lab, starting in November, we're going to start a monthly series. Each month, we will have a different topic dealing with lysis of adhesions. And we'll have articles, and we'll have once a month where Dr. Rácz will get on and we have office hours. So if you have questions, you can send them in advance. You can ask them at the time. We will set those up at times that are most convenient for everyone, but like today, we'll also record it because we know if you're working or you're sleeping or you just can't make it, we want to make sure that you get this information. Now, I know some of you have already signed up for that monthly education program. If you haven't, just go on to raxlab.com, sign up, and you'll start getting information in November. Later this month, I'll go ahead and send you an email just to give you a heads up when everything is going to start. Again, that's on raxlab.com, the monthly education program, and each month we'll have a topic that we'll cover, and Dr. Rácz will meet with you. So we've got a little bit more of our commercial break before we see Dr. Mishra. So if you need a quick break, go take it, or enjoy the commercials that we have coming up and videos for you.
Here's what's really good about the Epimed lead vests, is that you can have a wide variety of shapes and sizes, but most importantly, you can get material that is lead equivalent and that is ultralight. So what I'm talking about is 0.25 would be the actual thickness of the lead equivalent, but what that does is that really reduces the weight. So when we're talking about being in these procedures from 8 to 10 hours a day on a daily basis, our posture becomes pretty important and we just start to get tired over time. So when you wear a one piece, a single heavy lead, it's eventually going to start to pull down on your shoulders. It's going to affect your posture. Eventually, you might be the individual coming in for a pain procedure. So what I really like about the Epimed vest here is that we have the ability to get a skirt and a vest so we can distribute the weight. And I can also have the ultralight material, the 0.25 material that I spoke about. So I still ensure the maximum amount of protection, and I am easy to take it easy on my body as well with the actual weight being distributed. A two-piece vest is very important for distribution of weight. Because if you can imagine, so you're really just kind of having a half piece. So you put that half piece on, and then you wrap a skirt around. So when we go with this one piece, it's basically going all the way down, pretty much mid-thigh, anywhere to the knee. So it's all of that weight with that lead portion in front of you that's eventually just kind of pulling you down, right? But when you have just that two-piece, you're able to really distribute that weight, and you can really balance between upper and lower torso. The pain management industry it's a growing field. Whether you're working with pain management trained anesthesiologists, whether you're working with PM&R, there's a whole subset of classes in medicine that are using fluoroscopy and they're treating pain management procedures. And so what you have is when you don't have a national protocol or a way to educate individuals, you kind of get a lot of different stories and not everybody actually knows what's the best mode of operation. So what I really see here is really a need to kind of circle back and re-educate whether staff, providers, administrators, the whole gamut of the healthcare profession to really understand how important it is to protect yourself from radiation, specifically when you're exposed to it on a daily basis. And ultimately, if something detrimental was to happen to one of our employees because we weren't taking the proper radiation steps, that ultimately is going to lead to a loss of an employee. It could lead to a potential lawsuit. It's going to force you to hunt for new employees. Either way you look at it, it's not good. There's always going to be some form of a problem, basically, by not taking care of yourself properly. And so it's really all about education, and it's really about knowing the damages of the effects of this ionizing radiation to your health long term. And I believe if more individuals have seen some of the effects and know the risks involved, that you would see a movement in individuals trying to protect themselves a lot more than they currently do. There's certain things in business or life that they have to go with, you just need. So when you start a pain practice or you have a fluoro room or an x-ray room, lead goes with it. That's all there is to it. So what you want to do is you want to kind of run a equation in your head. How many individuals will be in my room when I'm doing my procedure? You'll most likely have an RN or a medical assistant, possibly an anesthesiologist, and obviously the doctor. So it's pretty safe to say that you should have a minimum of 4 pieces of lead. That's going to want to come with thyroids. It's going to want to come with eyewear, of course, as well. So now from that standpoint, you'd also want to think, well, what if we might have another member in the room? Will there ever be a rep in the room? Will there be a consultant in the room? So really what you need to do is, if you don't want to protect yourself, fair enough. You're going to have to protect other individuals who come into the room. It's essential to have a proper amount of radiation protection. You should be completely aware of the vital organs that can be damaged by this ionizing radiation. You should protect your eyes, you should protect your thyroid, you should protect your vital organs. You should be conscientious of patients who come into your procedure room who might be of childbearing ages, and we should definitely want to protect them as much as possible as well. So radiation protection, unfortunately, is a pretty important thing to what we do here. There's a cost associated with it, and it's one of these intangible things that you can't quite quantify and put your hand on. But long term down the road, if you didn't do your due diligence, you'd know why.
Our lecture is about radiation safety. Our purpose is to create awareness about the risk of radiation safety. The first alert for radiation safety, we should be more responsible to manage the interaction between X-rays and living matter. We have deterministic and stochastic effect. Deterministic effects require high doses. Radiation must be above threshold. The early manifestations appears in the course of hours, days, or weeks. The higher the doses, the bigger the lesion. Stochastic effects can be observed at low doses. There is no threshold. It is probabilistic. We need to create awareness about this risk for us, for our staff, for our patients.
Welcome back. We are headed back to the lab with Dr. Mishra. He is going to be doing transforaminal. And Dr. Raul Mishra is trained under Dr. Rácz at Texas Tech. He is has a biomedical engineering undergrad from Vanderbilt, and he practices here in the Dallas, Texas area. So we're very excited to head back to the lab and get started with Dr. Mishra.
Mishra. I practice right here in Frisco, Texas. We are at Baylor, and I'm doing interventional pain management with a group called Pain and Spine Physicians. And so this morning we're just going to talk about doing a transforaminal lysis. I know Dr. Rácz has gone over lumbar lysis, and we're going to go over a procedure about accessing the transforaminal approach to be able to do your lysis with the same type of equipment. I just want to talk for a few moments kind of about how I use this in my practice and kind of why you'd be using this approach. Dr. Rácz may have already kind of pointed out, and through some of the other presentations, that when we're doing a lysis, we're trying to break up scar tissue in an area where perhaps a nerve root is sequestered. And so accessing it through the caudal canal is usually a standard approach and usually very effective. There are some times where a nerve sometimes is not able to be accessed because of the amount of scar tissue. It could be because of a surgical complication in the past, or it could be because they have hardware. And so using a transforaminal approach is very effective because you're able to access directly where the nerve root comes out. So in my practice, it's very important for me to kind of identify the nerve that we are wanting to treat. I'll give you an example. We have patients that have multi-level fusions, and they'll have persistent leg pain. So in the picture of post-laminectomy syndrome, I'll get a nerve conduction study and kind of determine which nerve root we really need to address. And that's kind of an important diagnostic step that I take, because if they have a 2 or 3 level fusion and they're having persistent leg pain that is not really able to be discerned dermatomally, then I get a nerve conduction study to kind of identify, is it the L4, is it the L5, is it the S1 only? And by doing that, you can really target with something like a transforaminal lysis and get the catheter right to the spot that you need to. It is effective. It is also a little bit challenging. You have to kind of keep in mind that when you're using needles like an RX2, whether it be an 18 gauge or larger, getting into that space can be tough because of scar tissue that is there from either a previous surgery, if there's also foraminal collapse because of disc desiccation, and just the challenge of getting into someone that may have a scoliotic curve. So these are kind of things that you want to evaluate on MRI. So looking on the sagittal imaging and then also looking even on the live view when you're about to look under fluoro to make sure that you have good access, because of course you want to avoid things like nerve injury, and of course you want to avoid things like bleeding complications as well. Because anytime you pass a catheter or needle, of course you're going to be passing through a lot of sensitive tissue. You also want to be careful that as you are putting the fluid and treating the area, that you keep in mind and you're watching what the epidurogram looks like. So if you put a lot of fluid in that area, you can loculate the nerve, and you can also cause nerve strangulation, so to speak. And Dr. Rácz might have pointed that out in a previous talk, where he talks about making sure when you unlock the space, you use good volume, good pressure, and you go at a pretty steady pace, but you want to make sure that fluid has good runoff. If it loculates, you need to slow down and stop and wait for it to find its way out. Otherwise, the fluid will sit there and you can cause nerve damage as well. So I guess we can start by doing transforaminal, and unless we have questions that come in, of course we can stop and we can do that as well. So one thing I always do is I just check to make sure that I have good passage of the catheter through my needle, just as a safety check before I go in. I'll be using an 18 gauge RX2. We have a secondary stylet that usually comes with these. This one is an RX1, I believe. With the stylet, the RX2, I'm sure Dr. Rácz has pointed out, the operator stylet that goes in will allow the tip of the needle to become blunt, so that way if you turn it, it can push away sensitive neural tissue, and you can avoid transection, and you can avoid arterial damage or any other kind of venous damage. All right. Okay, let's take a picture here. All right. And if you can move towards the head there. That's good there, picture there. All right. So what we're looking at here is going to be probably looks like the L3-4 level. Let's see the picture. Oh, thank you so much. I appreciate it. Here's the operator stylet for this. So again, just want to demonstrate real fast here. We've got the standard stylet, which is here. It covers just to the edge. And you've got this step off, which allows it to be blunt. So that can be for safe passage. When I put the operator stylet in, you'll see that the edge of it sticks out just a little bit past. So if I freely rotate it, it will push that the nerve and the other sensitive structures away and prevents nerve damage. So that is a good thing to have on standby. All right. So here we're identifying the level that we need to take care of. Picture there. Let's see. I'm going to get a little bit higher up here. All right, so here we're looking at this level. I like to square off my end plate, and I do a right-sided oblique. We'll come in from the right side. Keep coming a little bit more. Keep coming. Take a picture there. All right, so what I'm looking for here, picture there, is going to be this opening here. So I'm trying to, I have the end plate squared off there at L3, and I like to get a little bit more oblique there. My preference is to come in a little bit more laterally than maybe some. This allows me to come in as close to the foramen as possible, and then right before I enter, I have the opportunity to kind of steer the needle anteriorly or posteriorly. If I take a little bit of oblique off, I'll show you here, picture there, you can see how I have less room, the opening of the foramen right here to right there, I have less of a window, so I'm almost guaranteed to go more anteriorly, and so I won't be able to kind of sneak in a little bit more anterior. So I oblique more, picture there, and a little bit off, a little bit, that's good there. That seems to be a good spot there. So I'll kind of line up there, roughly about here. One more picture there. Like so. After you, of course, local anesthesia. Usually I have the bevel of the RX needle pointing inferiorly, and then I'll use it to turn so I can get closer to my target. And you can see here that as I get closer, if I need to make an adjustment, I simply turn the needle and it will get me there a lot better. So you can see here that I'll have access to the posterior foramen, I can have access to the superior part, and if I need to dive down more, depending on the pathology, I have that ability, and I can even go anteriorly like so. So this is the reason why I try to get a little bit more oblique. It gives me a little bit bigger window to kind of get in. All right, good morning. My name is Dr. Once Rahul. I feel like I've got a pretty good angle, my needle's headed in a pretty good direction, try to keep it as coaxial as possible. What I'll do is then I'll get a lateral just to check my depth. To get the all right, are we able to kind of cone in a little bit there, or we can collimate it either way? Perfect. Great. So you can see here that we're kind of at a pretty reasonable depth here. My direction is good, my depth is good. I'm going to advance a little bit more with the needle. Again, I adjusted and I flipped the bevel because remember, as the needle advances this way, you have to redirect to kind of go superiorly so you kind of stay in a straight direction. If I leave my bevel pointing in one direction, I may end up, I may end up like that. And I will dive and I'll miss the foramen. So I want to, as I advance, turn the bevel of the needle superiorly and inferiorly, and that kind of helps me kind of fish into there. So as I get there to the end, I'm going to turn it again, and I feel a little bit of resistance here. That's I'm looking at the intertransverse ligament right here. Now, here's a situation where you have to kind of know the patient's MRI. You have to know, do I have foraminal collapse? Is there a significant disc desiccation? How much foraminal stenosis am I really dealing with? If there is severe foraminal stenosis, you have the option of, at this point, to use your operator stylet as you advance through the foramen. One of the techniques that Dr. Rácz likes to talk about is when you're accessing the S1 foramen, you want to make sure that you don't cause nerve injury right when you access through that S1. So here's a situation where it appears that I have plenty of room, so I should be able to get in pretty easily. If I wanted to just be very certain, I would remove the standard stylet, I'd take the operator stylet, put that in there. The picture won't probably look very much different, but you can know that the tip is in there, just so we like demonstrated. And what you would do is you would feel a little resistance here, and you would just kind of pop through, like so. And there's a little give that happens. So we take a picture here, and you can see that we're in the foramen. So before I turn it, and I have confirmed in my lateral view that I'm here, I'll come back and I'll check an AP. AP, yes, please, thank you. Well, and that's a good oblique view, actually, thank you for that. That's a good oblique view. It shows you kind of where we are. Now here, and do a little bit right rotation. I'm going to get the spinous process a little bit in the middle, kind of get a good AP shot. That's good there. So you can see that I'm pretty much through the intertransverse ligament. I'm going to turn my needle so it faces medially and slightly superior in this situation. The reason is because I'm trying to get in that direction. So here, with the operator stylet in, I'm going to advance just a little bit more. I'm going to feel a little bit, I'm going to push through that resistance, and I feel like I should be in there. Now you want to be careful not to go all the way across that pedicle. So that's what I'm watching for. So that is probably about where I would stop. I feel like I have a good entry. I will be underneath the nerve. Here's where you would take out the operator stylet. You could do a little epidurogram. You'd put a little contrast in, and you would see, is there spread? Of course, you want to verify if there's a significant amount of vascular uptake. Even if you have a little bit of vascular uptake, you're about to pass the catheter, you're probably okay. The main thing you want to make sure is that the contrast is actually flowing in and to your target. There are some times where the needle's position and where the nerve root is sitting, this might be enough to get your transforaminal lysis. In effect, depending on the anatomy, you might be able to get your contrast, your Hylenex, your hypertonic saline, just the way that Dr. Rácz has described previously, and be able to get to your target. But that, again, is dependent on your epidurogram. If, of course, you don't have an epidurogram that is to your liking, this is where you can take a catheter that you've already tested that will go through, and once you feel the end of it here, picture there, you're going to just pass through very gently, like so. Like so, picture there. And so this is where you would directionally target and get as far as you need to get close to the nerve root. Remember, and we're anterior, right? We came from the lateral view, and we're going to try to get to the anterior fibers. And so this would be a reasonable position depending on what your epidurogram shows, and this is where you would connect, of course, your stingray to the end of this, which we have here. So I take the stylet out here, attach this. You want to make sure that the marking on the catheter here, the stingray gets all the way there. If you leave it out, it'll be very hard to push fluid, and you may not be able to, so make sure that's nice and snug. You can always check a lateral just to see where the catheter position is. I'll frequently do that for a cervical lysis, just so I know that my catheter is sitting more anterior. On the AP view, it'll of course be sitting lateral, but you want to make sure it's not sitting lateral and posterior. You want to make sure it has come anteriorly. So we'll take a picture there, and you can see, if we zoom in and we take a little bit, there you go. You can see how it's sitting more anterior. So depending on the location of the nerve root and the anatomy, I would say this would be a reasonable position. Again, there's a little bit of variation to this because you want to make sure that your epidurogram is guiding where you're going to put the medication. So at this point, I've confirmed a great AP, a great lateral. I will, of course, take this off, do my epidurogram. Then I will proceed with doing Hylenex and doing the hypertonic saline infusion. Of course, you want to be a little bit gentle with how much and how fast you push because you're right next to the nerve root. You don't want to cause any kind of immediate nerve damage or swelling by pushing the fluid too hard, but you want to do it enough to try to break away the adhesion. And your epidurogram should improve. And what I see a lot of times is that you'll have a little bit of resistance, and it's okay to push through that resistance. If the resistance is not improving or the epidurogram isn't changing much, either you have to change the position of your catheter or consider that you may need a lot more fluid. As long as you have runoff, as long as you have fluid from here going downstream, you're okay. If it starts loculating, stop. And remember this, that the amount of local you may need here is going to be a lot less. So to anesthetize the area, you may not need a significant amount. Now sometimes, if you're in the OR, you may just do the infusion here. So I would do the Hylenex, and then put the hypertonic and slowly push it in here. You do have the option of course, once you've done the epidurogram, to take this stingray off, once you've done your epidurogram and your Hylenex. And what you would do here is keep an eye on where that catheter is sitting. And I would just leave the catheter there. The catheter tip is still sitting there. And my needle has now been pulled out, but the catheter is still there. I'll check an AP at this point. All right, and you see my catheter is still in a reasonably good position. I'm going to withdraw the needle more. Picture there. And you can see here my catheter is actually moved. So that's not a problem. I simply guide the needle back over this spot, and I'm going to just advance, picture there, with it right back to where I was. Picture. Of course, I'll have to get the stylet back in to get it a little bit more. Picture there. Okay. Picture. There. Okay, so I'm going to try to do my best to keep it there and not move it. Still good. And then out with this. I'm going to hold the catheter here and take the needle out slowly, like so. And so my catheter is still sitting there, and you have the option of taking that final picture, putting some sterile dressing and antibiotic ring, attaching the stingray to this, and then doing the infusion in the recovery area. So you've already put your local. The patient should be, plenty anesthetized, so they won't have a lot of discomfort. And you want to just be really careful that unlike a cervical lysis or a caudal lysis, you saw how easily the catheter moved. I barely moved the needle, and this thing just slid right out. So you want to make sure multiple times after you fixed it and everything that the tip of the catheter is where you want it to be. It's a little bit tricky, which is why I would recommend that you just do the infusion while the patient is on the bed, because you have a lot less wiggle room here. Again, with the caudal or with the cervical or even a thoracic, you've got a lot more leeway with the catheter tip to stay in the position where it needs to be. And then, of course, once they are done, you've done a neuro check, you'll be able to, when you're done with your infusion, you simply should be able to slide this out without resistance. If there is any resistance when you're pulling it out, go back under a fluoro, check to see what the positioning is, restylate it, try to snake the needle over the catheter again, and see if you can just come out. I've never had that happen where a catheter does get stuck. It's just very easily comes out. And that's the reason you use Epimed products. They do a really good job with that. You can kind of assure the safety, of course, by using the needle and the operator stylet, and you should be able to do it. So I think that's a demonstration that I would do on a right-sided L3-4 transforaminal. And if I have any questions, I'd be happy to answer those at this time.
The question is, would a blunt needle approach be much different?
The question is, was a blunt needle approach different? Meaning if we use just a, like a 22 gauge blunt needle? No, the approach would be the same. The only difference is there's no operator stylet there, but you would pass and do the transforaminal the same way. And again, the key is your epidurogram. So you can use a blunt tip needle, do the same AP and lateral view, and then you would of course do the infusion in the OR and not have that one option to be able to remove the needle and do the infusion in the recovery area.
They're asking about the demonstrating S1 transforaminal approach. That approach will be demonstrated by Dr. Rácz this afternoon. Is there a subdural risk also?
Yes, there is a subdural risk. There's a risk for that essentially anywhere you do in the spine with lysis or really with any injection. So that's where the epidurogram is very, very key. If you can track that initial epidurogram, so once your needle is in a proper position, make sure the spread of your medication is confirmed in AP and lateral view to avoid that. And that's one of the other things that you can kind of do before you do the infusion is that let's say your epidurogram looks adequate. Once you put that local in, you've got to make sure that they get a good anesthetic level on that leg or the arm, depending on kind of where you're doing your lysis. But in this particular instance, we're doing a lumbar transforaminal. You want to make sure that they're getting a good anesthetic on that leg and not a subdural block. So that's where the neurocheck comes in play if you wanted to do that in the recovery area.
Would it be possible for you to demonstrate a thoracic transforaminal approach?
Yeah. You have to. Yeah, we could do that if you wanted to. Sure. It's very similar. The process is very, very the same as far as the AP and the lateral view on that. Of course, you're dealing with the thoracic cord being there, so you have to be just more careful about how much you come across the pedicle, but it would be essentially the same. I don't mind showing it, but it would be essentially the same. We're just kind of in the thoracic spine.
There's a question here saying, is it frequently provoke a paresthesia with the blunt needle comparing with the traditional needle?
No, I think that the paresthesia would be elicited if you had a sharp needle go there because you have the possibility of disrupting some of the neural fibers. In my experience, I don't recall really having a paresthesia elicited when you're using a blunt tip needle. Again, when you're advancing with the operator stylet, you're pushing kind of neural fibers away. They may get a paresthesia just from the fact that if you have a component of foraminal stenosis, and you're, of course, introducing yet another object into a place that's already stenosed, they may get some sort of paresthesia, but generally no. I don't recall that you would get a paresthesia with a blunt tip needle. I think it'd be more common with a sharp.
How long do you wait until you infuse hypertonic saline?
So if I'm doing the anesthetic and then waiting in the recovery, I'll probably wait about 15 minutes to make sure to avoid things like a dural block. If they have a dural block, of course, you're not going to do the hypertonic, but about 15 minutes I think is adequate. It just kind of depends on what level and what the patient's pain tolerance is. Sometimes the block sets up more quickly, sometimes it takes a little bit longer. You'll get that feedback from them once you start the infusion. If they get very uncomfortable even after you waited 15 minutes, wait another 5-10 minutes. Let the anesthetic really settle in. You may have to redose it and then do the infusion slower. That's also possible, but about 15 minutes or so, maybe 20.
He says thank you. Dr. Guzman says thank you. Next question is, can this be performed using ultrasound?
Short answer, I would say no. You need a fluoroscopy to see the epidurogram. You could probably get the needle placement under ultrasound, but I think viewing the fluid, I think fluoroscopy, you really need to be able to use the x-ray to see the AP and lateral view. I think the ultrasound can be used as an adjunct if you wanted to kind of really localize the nerve in the foramen, but I think fluoroscopy is a must. You've got to be able to visualize it. And just to kind of give you an insight, when I do lysis, depending on the patient's presentation, new patient comes in, they've got radicular pain, I'll do a standard transforaminal first, just because I want to see what the epidurogram looks like. Do they get any relief? That epidurogram is kind of my baseline, because the next time I do, then I go and do a lysis, right? So that for me, I'm able to document kind of the progression. And many times you'll see the epidurogram. You'll probably hear Dr. Rácz use that word boomerang, right? Like it just kind of opens up this way. When you do your transforaminal the first time, it spreads, but it doesn't spread very well, so you take what you get there. You go back in there and do a lysis, all of a sudden you see this pocket just open like this. And that's a really good visual that you can show your patients that say, hey, I just did a standard injection on you a month ago. I just did a lysis on you 2 weeks ago. Look at the difference. And I think that's really helpful. So I think that's just a little bit of insight kind of on the clinical part there too.
Why do you go for anterior, and is it safer to aim for Cambin's triangle?
That's a great question. I'm going to defer that to Dr. Rácz. He's got a lot of experience. He's probably done about, I don't know, a couple 5 million more than I have to really get into that. I do have an opinion on that, but I think that I would probably defer that to Dr. Rácz. I think his take on it, after having done so many and in the papers that he's written, I think he'll be able to kind of provide a much more succinct response.
Yeah, I think the one thing about the anterior is he always says that is where all the pain generators are.
Correct.
Nothing
Correct.
posterior.
Dr. Rácz, so good to see you, sir. We do one of these, that's right. Yes, sir.
Dr. Rácz, there was a question here that Dr. Mishra was going to throw that at you. Why do you aim for the anterior, and would it be safer to aim for the Cambin triangle?
I don't think the triangle is useful anymore. I personally just touch the superior pars and navigate around it, and as soon as we head backwards, see, up to that point there are no nerves, arteries, vessels, there's nothing there to get to the superior parts. Just look at the X-ray. And then when you start rotating around, by then you should have the second stylet in place, so that when you get into the neural foramen, you go all the way down and touch the bone and make sure there's no pain. The damage you can do is if the nerve is stuck down, you can neuropraxia, that's pressure injury to the nerve, and it is not a good idea. So you just avoid, because you don't have to put pressure to cause pain. And then as soon as you are on bone, take the second stylet out, and you can thread the catheter. The target is mid-canal, and that is what resolves back pain. I firmly believe that non-specific back pain is a non-specific nonsense. It's very specific. Kozlich has heavily documented it mechanically, electrically stimulating in large numbers of patients. That's the most painful structure in the back. The two Korean papers, one is a small volume transforaminal, the other one is a larger volume transforaminal. The small volume works on radiculopathy. The larger volume works on radiculopathy and back pain. And what you have here is an opportunity to go all the way in to mid-canal and put the hypertonic, which specifically disconnects C fibers for many years. And that's why I mentioned that when the pain comes back, it comes back on the other side from where you work or at a different level, because most of our activity works on the specific side where where the patient has the most pain on, but it's not as convincing as the area where you worked on the other side or at different levels. And that's the problem of surgery. And the additional problem is we'll be talking about the scarring triangle and the S1. That's a different animal altogether. It's a different, but I would say no to the triangle, the Camberland's triangle. It used to be of some use, but not anymore since we have the recognition of where the pain is coming from and what the heck we are doing.
Two more questions. Dr. Mishra, are you going to aspirate before the infusion, and how do you differentiate the back fluid from CSF?
That's a good question, and yes, always negative aspiration. You always want to make sure that you are, again, we're treating pathology, so we're going to assume there's foraminal stenosis, there is less room. You want to make sure that as you pass a needle, a catheter, anything in there, that you are not cannulating into something. I think that if you get CSF, you have certainly gone way too medial with your needle. I think if you get CSF, it'll be incredibly obvious. You will get backflow almost without the aspiration. I think that if you advance an object and you get through the dural sac, you will get backflow regardless of where you're on the spine. Am I right, Dr. Rácz? You will get that. You would have gone too far.
I completely agree. I think I was very impressed when you were doing it. You have such nice hands, you know? That's beautiful to see somebody who is caring, but hands don't make up for a second stylet. And that, you know, a needle tip can cut. You cannot move it. You can move it when you have the catheter in, because it goes out. Now the issue of should you put contrast in, for example, on the second and third injection, I have never seen this catheter move ever into the subdural, subarachnoid, because it's tightly held in position. There's no movement. There's curvatures in it. There's plenty of give, but yes, I do agree. Very nicely done, Rahul. I'm very, very proud of you.
Thank you, Dr. Rácz.
Another question, which is a good question. Why would you not go with from the sacral hiatus? In other words, why are you doing a lysis with transforaminal? Why are you going with a transforaminal lysis and not going from the sacral hiatus?
Because the problem of the sacral hiatus is the scarring triangle, because any scarring can spread, and it can spread down and cause massive bladder dysfunction. And we can reverse that, and that's where the scarring triangle comes in. And you cannot get, because of the curvature of the sacral spine, you cannot get ventral. It just doesn't.
We're asking, he's doing a transforaminal lumbar lysis.
Yeah.
Why wouldn't you just do the sacral hiatus? Whenever I've seen you do that, it's because you couldn't get to the site.
The scarring triangle issues. No, wait. I get it. It's very, very rare, and most of the time you can do it through the sacral hiatus, but you cannot do it at spinal stenosis at the stenotic level. There you need to go transforaminally at the narrowest part of the area, and you do open it up so long as you are mid-canal. And I think it was a beautifully done mid-canal that it really is amazing how rarely you fail with that, almost never. The technique has been worked out so well. And it's amazing how useless, utterly useless, epidural steroids are for spinal stenosis, because they cannot get into that narrowed segment. So you guys better listen, because if you want to have useless procedures, keep doing epidural steroids. But it's just like less than useless.
One last question. Can we inject PRP, especially when a nerve injury is caused?
Well, it's less than approved. PRP in a spinal canal. You see, every step of what we've been talking about has been approved. And if you challenge insurance companies, they will lose every time. One of my patients just had an enormous settlement. I don't know how much, but he's very happy. But you cannot accept denials for not approving. But one of my dear friends, Ricardo Ruiz Lopez, he believes that PRP is phenomenally effective, but I would say that it would be effective maybe once you open up the stuck down area, and then there is magic. We don't know everything. And when somebody who's a serious neurosurgeon goes and does it, well, I stop and listen and give. The credibility has to be there, because I exposed myself to every form of injection through post-irradiation pain I had in my shoulders and knees, but eventually surgery is needed in some instances. Like, I'm very happy with 2 new knees. But please note that as I'm speaking here, my shoulders are protected, and none of your shoulders are ever protected. It's almost exposing your shoulders. So anyway,
I wanted to add.
I want to get your take.
Yeah, so I wanted to just add on the back of what Dr. Rácz was just saying. I think it's very important that we kind of point out what Dr. Rácz had mentioned was that PRP can be effective. It is, still very well proven for joints and ligaments and those things. But the key, I think, that he said that I want to underscore is that he said you've got to open up the space before you put in PRP. So, and I want to just kind of unpack that. What that means is that, let's say you've got a nerve injury, let's say you've got a posterior annular tear, and you're really trying to keep this patient from becoming a surgical candidate, maybe because they don't need a disc replacement. The key is that once you get your catheter in, you've got to hit the target. Because if there's scarring, it's there because of inflammation, the nerve root is sequestered. If you can if you can just get that open and get a good epidurogram, it means you've got fluid flow. That's the first step. If you've got good fluid flow, by all means, go back in and put a little bit of PRP and see if the growth factors can help heal the annular tear or help the injured nerve. But again, going back to the point is that the lysis is there to open the pathway to get there. And the analogy would be analogous to, gosh, any road in Dallas downtown, if there's a pothole, you're not going to get to the pothole if you can't get the cement truck down there, right? Like, you've got to clear a path to get there before you drop the PRP and fix the road. So you can put all the PRP you want, but you've got to make sure you've got a great handle on getting that space open, getting a good epidurogram, and getting a diagnostic good relief. Like, the patient's got to say, wow, my leg actually feels 70% better. Like, I'm not completely, but if I'm getting there. Well, that would confirm my good epidurogram. Go back and put PRP in. Now you've got a pathway to do that. And then going back to the first point was about the insurance, is that, yeah, that's not a covered procedure. So of course that's something you have to discuss with your patient about how you will have them cover that cost. But it can be very effective once you've cleared the path. So I just want to make sure I kind of point that out. All right, thank you so much for your time. Appreciate it, and happy lysing. All right.
The best tip for getting to a target site is, number one, slow down and see where the catheter is going. You should be just a little bit close off midline towards the target site. You steer with the tip of the needle and put a bend in the catheter. For the lumbar area, the longer of the marks on the catheter, what you use, is about 1 inch. For the thoracic and cervical area, the shorter one. You put a little 15-degree bend. And you go slowly under continuous fluoroscopy. This is why radiation safety comes in very important. The X-ray, instead of being straight anterior-posterior, in more capillate tilt and just show the tip of the needle. And then you slow down while you are directing, and you navigate the catheter down. Once the catheter is diving down, it's always ventral. If it points towards the middle, that's usually posterior. So once you're in a ventrolateral epidural space, you verify it by looking on the lateral view. And then you inject a contrast hyaluronidase, the local steroid, and wait 30 minutes, the hypertonic saline. That is by far the best tip. The problems I see people cause when they don't put a band on the catheter, don't look at, just ram it up, and go through the tip of the dura, subdural, and then they say, well, the problem was caused by chemical neuritis. Nonsense. I don't see chemical neuritis. The problem comes from the hypertonic saline or anything, you large volume, inject in the subdural space, draws fluid, and it's going to be sort of a, they draw fluid from anything. It's almost milky. I've been told by a spine surgeon that milky fluid, and so I said, show me the pictures. Well, we don't have pictures. Well, show me. It's one of the young guys comes out with the pictures. I said, look, you are in the subdural space. That is not where you should be with hypertonic saline. You should be in a ventrolateral space so it spreads onto the posterior longitudinal ligament where most of the pain fibers are. The sinovertebral system is very richly innervating the ventrolateral epidural spaces. Less so in the posterior area. There are fibers there too. But the biggest pain generator is in the ventral epidural space. So that's where the hypertonic saline belongs. That's where you get the back pain relief, because hypertonic saline disconnects C fibers. We've got a couple of papers on that, and they're in the references.
Hello, my name is Dr. Rácz. I am a private practice interventional pain physician who practices here in the Dallas area. I am talking today about sphenopalatine blockade. So think of it as, you know how you know what occipital neuralgia is, coming from the neck and all that, and then there's headaches, and sometimes headaches are just like global. But with this kind of neuralgia, this is where people get lancinating, like facial pain, or you know how somebody says, I have this pain behind the eye on this side only. You know, if you've ever seen that, people get migraines and it gets just, and when that's intractable, like a lot of times if I have women get this a lot, and it's so easy to put in the pledgets in their nose. I mean, it's the wildest thing. These pledgets are like this long. And, you know, if you think about your nose, you think it ends like right here, but actually, you know, your sinus goes all to the back of your mouth. So you put this pledget in, and you'd think that it kind of goes up. You think your nose goes up, but truthfully, your nose goes straight back. So you're putting this pledget in, and it just goes straight back, and they freak out when you first time you do it, because you dip it in local, and you have them lay there, and you tell them, this is going to be a little uncomfortable, and it stimulates a reflex, so they always, one eye will just start crying, and you just stick this thing down, and this pledget is this long, and by the end, that much is sticking out, and then you put 2 on each side, and then I literally I turn off the light, and I say, listen, just lay here for 15 minutes, we'll be back, and I tell the nurses in 15 minutes, they go back in, they just take them out, it's covered in snot, we give them a tissue to blow in and blow it all out. But when they have this kind of headache, it's almost like in 20 minutes, it just kind of like eases up and goes away. It's amazing. This is a simple technique that can be done in the office without sedation that can give temporary relief for acute, as well as be performed as a diagnostic block. Another approach is a intraoral approach, targeting a dental needle just at the mucosal line of the 3rd molar and advancing down. This sometimes is done without fluoroscopy and can stimulate a trigeminal branch and can be done again as a diagnostic block. The technique that we use commonly is a lateral approach, and this is performed as an outpatient with the patient given some mild sedation, either Versed, fentanyl, possibly a little propofol, following ASA guidelines for sedation of interventional techniques. The patient is brought to the surgery center and placed in the supine position with the head straight up and the nose pointing straight up. Under AP and lateral views, I like to identify the posterior nasal bridge, and in the lateral views, you line up the zygoma and the pteropalatine plates. The sphenopalatine fossa looks like a vase in the lateral view with a triangle that is easily identified once you line up the plates that are behind the maxillary bridge, the posterior border of the maxillary sinus. For pre-medication, we'll use light sedation with possibly Versed or fentanyl. Depending on the patient, we may even use some propofol IV medication for patient comfort, as well as to optimize needle placement with the patient lying in the supine position. For the injectate, for a local anesthetic, we'll inject either 0.25 or 0.5% Marcaine or possibly 0.2% ropivacaine mixed with possibly some steroids such as depomedrol or Kenalog. The sphenopalatine ganglion has both sensory and motor as well as autonomic branches. The sensory branches come off of the maxillary nerve. The autonomic supply is complicated, and interestingly, there is a branch that goes through the maxillary sinus to the lacrimal gland. And therefore, with stimulation, you can actually have some unilateral tearing on that side as a reflex phenomenon. One tip that I use under fluoroscopy in the lateral view to properly visualize the pterygopalatine fossa that looks like a vase triangle is to have the patient laying supine and to using the bridge of their nose to tilt their head back and forth, left and right. This helps to line up the pterygopalatine plates and line up the edge of the mandibles to optimally be able to visualize the fossa. This is a oblique view to optimize visualization of the pterygopalatine plates and the sphenoid fossa. This is the coronoid notch with the mandibular plates and the mandible. Skin entry would be right between the coronoid notch below the mandible, advancing down the superficial tissues, I use local skin infiltration and advance with a direct, small, short access needle and break the superficial tissue to about this level, about the level of the mandible. I then like to remove the sharp stylet and advance. I like to use a 22 gauge curved blunt needle. And in this approach, we advance slowly using the curve to go more medial if needed. And when you hit on a bone, which would be the pterygopalatine plate, you can turn a little more dorsal posterior and advance to the sphenopalatine fossa. I then get an AP view and confirm placement with the AP looking down on the face. Complications with this procedure include bleeding, infection, and nerve damage. Specifically, we worry about bleeding into the superficial tissues of the cheek. We also have concerns for sympathetic blockade, concern for intravascular injections, and as well as subarachnoid injections based on location into the cavernous sinus. Depending on the response from this block and how much relief the patient can get, it is not unusual to repeat the injection in 1 to 2 weeks if indicated. So in conclusion, sphenopalatine block can be very effective, simple, and safe treatment for treatment of intractable pains, including headaches and neuralgias, as well as atypical facial pain in those patients who have not responded to more conservative therapies such as medication management. Depending on how long the patient gets relief for and the intensity of relief, another option would be to proceed with sphenopalatine radiofrequency.
Welcome back. So good to see you. We are getting ready to go back into the lab with Dr. Rácz. He's going to be doing cervical, and we appreciate all the questions that we're getting. So please feel free, if you have any questions, use that chat box. And if you have a private question or just need a little bit more clarification, you can go into one of our 2 Zoom rooms that are below. I know Dr. Rácz has discussed a couple of different articles and white papers. If you haven't already, you can scroll to the bottom of the screen and you'll be able to see all of that literature there. After our cervical discussion, which will be about an hour, we will take a little bit longer break. For our American doctors, if you will join us in the Zoom room, we will be doing a special lecture for you with our Director of Physician Services, Meredith George. She will be talking about reimbursement. So bring your questions, join her, and then this afternoon, after our break, we will come back into the lab. We'll be doing S1 and scarring triangle with Dr. Rácz, followed by a discussion with Dr. Ira Fox, where he's going to talk about lysis in private practice. So we look forward to continued education today. Once again, use our chat box, and let's head on over and see Dr. Rácz as he does cervical lysis.
Live in 2 seconds.
Is it cervical?
Yep.
Well, I need to open up the neck.
You want to slide this up or just?
Yeah. Okay, let me see.
Okay.
Straight AP.
Straight.
Okay. Okay. Well, let me just maybe picture. Okay. Picture. Picture. You have the pen. The commonest problem of cervical neuroplasty is the patient positioning. And number one thing is you should use a small pillow under the chest. Number two, no headrest. If you stabilize and push the head back, especially in the elderly, which is a lot of our patients, it virtually shuts down the spinous process to let you in with a sizable needle. Now, most of the time, it doesn't matter what needle size you use. You can use a 14 gauge needle for spinal cord stimulators. But by and large, an awful lot of people use the 18 gauge with a versacast, because you become so easy and so used to it. But the technique, I believe, it should not ever be midline. It's avoidance of hematomas, an avoidance of getting into the spinal cord. And I have been seeing a lot of intracord needle placements because people are going midline and expecting to feel the ligamentum flavum, and when you go midline, there's a very high incidence of a gap at the level when you go in, and by bad luck you can hit that gap and you walk in when you go in the midline, and the first loss of resistance is a dura, and as you go a little bit further and you're in the cord. It is unconscionable, really. So I think the technique should be direction, depth, direction. It, first of all, starts somewhere. What level it should be your number one decision. And recently, Stan Helm and I, we put a paper, I think it's in Pain Physician, where we put in a venous plexus anatomy, which is that the venous system in the neck is mainly ventral. Virtually no veins are fluor. Picture. Virtually no veins are visible at the posterior C7 T1. You have most of the veins come into view at T1-2. Like recently, picture. Recently, picture. there were 2 cases of hematomas with sort of stormy outcome published there because they both were at T1 too. So use C7 T1 as your selection for the site. So we're going to go in at, start below, let's see, what needle do we have? We use an 18 gauge RX2 today. I don't see the second stylet. Picture. So we are heading towards the target, and I'm going to picture, aim, so it's direction, depth, direction. In other words, I'm aiming for the midline at C7 T1, and I am on T1, and on my way to the midline, I hit the lamina of T1. And now I correct the direction of the needle, and I'm on my way to the ligamentum flavum, and then I rotate it down, and I can feel the, I'm touching the bone. And this happens in about, I don't know, a few seconds, that I'm already just outside of the ligamentum flavum. Now, lateral view, and you will be looking for the straight line, and I am totally safe. There's no vessels, there's nothing in the way. And if you think about your suspense when you do a cervical shot, particularly single shot, in view of the gap in the ligamentum flavum, close the white out, collimate it down. I need a little bit of cleaning up of shooting straight across the parallax. You see, the straight line that we're looking for is right here. Look, you've got to get all this white out. You see the straight line is cortex, 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 cortex. Here's the bifurcation of the spinous process. And now I am still a long way. This is where the ligamentum flavum is attached. So I still have a long way to go until I reach the ligamentum flavum. So I can go further. I feel the bone, and we are still picture. Now I'm sitting on the ligamentum flavum, and I felt it, and I can almost go in, and there are no veins there. At C7T1, but I should put the second stylet. Interlock it, and I can go in freehand. I think I'm right through the ligamentum flavum, not by intention, but it just happened, because this, normally I would have the head dangling down and this cadaver, and then I usually use 4 cc's of air and 6 cc's of saline, and I bounce, but I'm in. And then we put the stylet back. And rotate it up towards the other side, picture. And take a Versacast, AP, please. Versacast is so soft, and I usually put a little bend in it by running my nail down, and that gives it a no bend. And I just tilt it at an angle to show the tip of the other way. Keep my hands out of the beam, just show the tip of the needle. See, in '86, I have pictures published that I was losing my fingers. And there you can see I'm already at C8. Or C7. Anyway, so if we want to go higher up, just move up so that you see just the tip of the needle. Okay? And I'm going to pull it back. Rotate a bit up. Picture. Oh, it went all the way out. Okay. Flora? Flora? Now we are sliding up and hanging up on the pillar there. I rotated too far over, so I'm just pulling it back. Picture. Oh, it went all the way out. So you picture. Flora, continuous flora. Now, there's a little trick you can do. Pull the stylet back. And then you rotate it. You see, once you soften the tip, you can have vertical stiffness, and you can fiddle with it, and then ease the stylet either back or
Do you ever put the stingray onto the catheter in and then put the stylet through it?
Sorry?
You know when you put the stingray on the catheter, you put the stylet through the stingray?
Yeah, okay, that's another trick. Good idea, but I'm just trying to straighten out the tip because I want the tip to be pointed out. Into the neural foramen. And one thing recommended here for putting in the stingray connector and you have to push it into the black mark. Putting the stylet through the stingray. Yeah, it has a considerable flora. These are the joys of cervical. But you can see that you basically, if you fiddle enough, you can get it virtually anywhere. Versus if you use a stiffer catheter, well, we are in the direction. amazingly, you can spread the contrast better when you do flexion rotation. Carlos, point to my face. So that as the patient is hanging loosely over the pillow and then rotate chin to shoulder, left and right, and when it's flexion and rotation, it makes the neural foramen bigger. There is a paper, I believe in pain physician or pain practice by Kitagawa, and he did a CAT scan study showing that flexion enlarges the neural foramen and extension makes it smaller. But flexion, rotation moves the dura. And Carlos, do we have that clip? Can we put on the clip? And you will see here something that is really truly mind-blowing, changes your practice. And where it will, can we put it on? Put it on right now. It's playing. Can I see it? No.
That's beautiful.
And what I want you to see is the electrodes on the it's look at the up and down movement, and it's really not fully flexion, but just I am working on this lady's neck to open up. She had a left-sided C5-6 radiculopathy and previously had electrodes placed, 3 of them, for atypical facial pain. And the electrodes are stuck to the dura. And what you can see is on the lateral view is almost a full thickness, a full vertebral body extent is moving up and down. Now, if you bend forward as much as you can and then move the head and neck down, then you get really very nice movement. And that movement translates into down to the scarring triangle in the sacral area, where the dura moves and pulls on the area where the adhesions are. And this can be predicted before surgery, because nobody gets to the scarring triangle, because even when you have an artificial disc and the dura still is stuck to the ventral epidural space above the disc replacement, they still have this tremendous low back pain. And the scarring triangle is going to be an extension that we learned from this very case. And I have another look at her because she had some pain return 2.5, 3 years later after my cervical neuroplasty here, what you are watching on the left side of the cervical spine. And then I had to go on the right side of the cervical spine 2.5 years later because the other side acted up. But now it's several years later, and the patient is doing very well. Now, to show that we can do the cervical neuroplasty with a bigger needle. How's our time, Carlos? We'll try it with, if we have time, a 16 gauge needle. Picture. Come order.
40 minutes.
How many minutes?
40 minutes.
40? So I have lots of time. Okay, okay, so we need to go higher. Picture. Now we are on the so the technique is direction, depth, direction. So now I will rotate the needle tip. Picture. I'm still on bone, and now I'm going to walk off a little bit and start curving down. Picture. And now we're going to lateral view. So I am looking for the straight line. And this is where you are having the insecurities when you are fairly deep and you don't know what you are doing when you do a blind epidural steroid. Now you've got to lock the white stuff out. And suddenly the magic of anatomy, you see, here you have the straight line with a V for the bifurcation for the lamina, and I still have that much time, that much space to go, and within literally, and now I am just advancing a bit. Okay, now we rotate down, and when I rotate down, you should never go with the sharp edge. You see, the tip of the needle now is parallel to the ligamentum flavum. And then I can, unlike the first time, we'll do it with loss of resistance. And I'm in, picture. And you see there's nothing sharp pointing at the dura. And now we put the second stylet in. And rotate around. Picture. Now the picture, you see the pressure from the catheter is going parallel to the dura. So if I can find a brevi, and this is where the two marks come in very handy, and this is the neck. Make sure that the stylet to the end, and I'm going to bend it on the second shorter area, the mark. Remember, this was my comment about fellows cannot tell an inch from half an inch or thereabouts. And now we'll go to the right side picture. AP, please. And we are outside the tilted cephalad. Just get my fingers out. Just move further forward. Now, see, this is a more stiff catheter, okay, picture. And we'll try to do the trick. I'm going to try to bend the picture. So we made it up higher, picture, Flora. Tilt it a little bit. So we can go up all the way to C2. But push back the stylet. Picture. Picture. 8, 7, 6, 5. So you can go and inject any nerve root. And when you run into a ridge, a bony ridge, I just pull back on the stylet a little bit so that we can picture and soften the tip by bending. Picture, Flora. See, it's hanging up a little bit, and we rotate. Picture. Picture. But this is where injection of saline or hyaluronidase will change, your life. And sometimes it takes a little time to fiddle with it, but picture. We'll see if it picture. It's hanging up on something there. Anyway, picture. In the neck area, sometimes I find if there's a severe radiculopathy, I have to do a transforaminal catheter. And that is sort of black belt stuff in the neck. And when you do an upper cervical transforaminal, for some of the headaches, it really makes a huge difference, because cervicogenic headache can come from the dura being stuck to the discs and opening up the area. It's hair-raising, but it makes a huge, big difference. And you don't get brave in the head because the blood supply to the cord is coming with the nerve roots, and you cannot use a lot of force. But when you have a catheter in place and put 1/10 of a cc of contrast, and then the hyaluronidase, I can put really high pressure, and gradually I see, because the patient is not heavily sedated, is talking to me, so there is no loss of function or no pain related to compression of the cord, so you can make some significant improvements, but we are not talking about the transforaminal at this time. I just wanted to mention that in some of my very, very tricky cases. Now, what would be a contraindication for you to go in? If there is syrinx, please don't consider any procedure. You must review the MRI, and looking at the cross-section of the MRI, you must have spinal fluid around the cord. And thinking back to my 158 cases I've done in Korea, doing 1, 2, 3 cases in different big spine hospitals, and they would have the patient on the table, a brief discussion, review the MRI, and I got to one of them and looked, and had multiple neck surgeries, tremendous pain, and I said, I'm sorry, but I'm not going to do that. And he says, why not? I've done worse, says my guest, my inviting doctor. And I said, well, yes, but there's a difference. I want to go home. I don't want to go to a Korean jail from doing something. So I would pass this story on, that when you don't see spinal fluid around the cord, you don't touch it. Some cases are not doable. And sometimes you just have to know that this is beyond anything you can handle. And there are some cases, but generally speaking, what you have seen so far, that I find that getting in is the biggest problem in a 90-some years old. Like one of my patients was the regional medical director for Medicare and former professor and chairman, dean, and member of the American Board of Orthopedic Surgery, and I almost couldn't get in because I overlooked the fact that somebody put a headrest in. So when you put a headrest, you push the head back and it shuts down in a very significant, so you have to look at every possible detail, and then suddenly you get spectacular results. For example, my daughter is a ballerina and an artistic director, and had 2-level bulging discs and couldn't raise her arm, and she had a lead role in Nutcracker and Sugar Plum Fairy, had to dance in like 3 weeks' time, and severe pain, and that was about 14, 15 years ago. And then I was able to get in, and actually looking back, it was one of my younger colleagues that did it, and I was in the room. And other than physical therapy, stretching, post-procedure, 3 weeks later she danced the Sugar Plum Fairy, and we never ever had to go back in her neck pain again. Remember the neuroplasty lysis of adhesion first edition in '89. Our patient, my patient, who came from a long way away, could not raise his leg like 5-10 degrees, and so severe radiculopathy from a leaky disc. So I did a neuroplasty on him, a caudal. We did not know at that point about transforaminal catheters. And 3 daily hypertonics, and he went back to work, started his own business, and 22 years later he came back and he re-scarred the same area. And we did not do as well as the first time because we did not know about the scarring triangle. And he was not so happy, but 22 years later. And I have the pictures in the second edition of the book that was in 2016 or thereabouts, Techniques of Neurolysis, second edition. This time I had Dr. No as a co-editor. And you can see that the scarring triangle forces your catheter posteriorly, and we could not open up ever the area of the scarring triangle. Anyway, cervical neuroplasty is one of the most significantly effective procedures. It's amazingly good, and surgery if it's needed, if there is instability. but there's very rarely instability. But it substantiates and removes the pain from areas that we can reach. And if we did contrast injections, you would be seeing where there's a filling defect. And that's why I was going after the transforaminal with a technique that I can describe it, that do it in the supine, mark the posterior border of the lateral structures, elements, the transverse processes, and then coming with a marker and look at where the target site is, and behind the neural foramina and the vessels and nerves is my mark for the posterior border, and then put a mark crossing the target, and come in at the target and touch bone, and now using the curvature of the needle and changing the oblique C-arm view to 30 degrees, and I go until I am just at entering the neural foramen, and then rotate down with the second stylated needle and enter the neural foramen, and then you can, once I'm in the neural foramen a short distance, then we push the catheter, and the catheter will follow the nerve root and go into the top of the neural foramen to the so it follows the dura, and I can get it to mid-canal with the very tiny versicath, which and then proceed with the injections. And I just wonder if anybody has any questions, and maybe see here we have our assistants. Anyway, you've seen us do the 18 gauge, 16 gauge, and mentioned in passing how to, the generation of the next wave that is coming, which is the cervical transforaminal, by avoiding any vascular structures with anything sharp.
Well, the question is, can we do this the foraminal way?
Sorry?
Can we do this the foraminal way?
Yes, transforaminal, yeah.
With a needle and catheter?
You can do it, but any transforaminal injection in the neck should never be done with a sharp needle. It has to be done either with a blunt needle. The problem with the blunt needle technique is that you I'm afraid to go with a needle all the way into the spinal canal. And using a tiny catheter, the Versacath, it goes straight in to exact target area. And we have had some very good results, but it's not at the point where I would recommend to anybody who's never done it before. You need to have the savvy, because that's where compression and localization is the biggest problem area. But the hyaluronidase, what I have found so far, finds the way back, and the first step is 1/10 of a milliliter of contrast, and follow it with hyaluronidase, and the hyaluronidase comes back towards along the catheter and spreads and opens up the posterior the posterior to the disc epidural space in the ventral epidural space.
Next question is, what is your needle entry site for cervical and why?
What is
your needle entry point and why?
I am at the level of the pedicle below the target. And the reason is that I usually go contralateral from the area where I have to go, and I aim from that point to the I aim from the entry point to the midline, the interspinous spot above. But in between, along the straight line, I curve down and touch the lamina. It tells me the depth. I am still outside from the straight line. And then I correct the needle to get off the lamina. Then I rotate back and keep going in the direction of the midline. Then I switch to lateral view and advance the styleted needle to the level where I know the ligamentum flavum is, just a little bit posterior to the straight line, and then loss of resistance, it's loss of bounce, and I pop in, and then I switch over to the second stylet, and then advance. Once I am in epidural space, I advance it and pointing in a direction. But at no time do I have a needle that is sharp. I go into the epidural space curving down, not curving up, curving down, so that the flat part of the needle is heading in the direction of the, if you look at the tip of the needle, there's nothing sharp when I'm going at an angle. And once I pop in, then put the second stylet in, and then I can rotate around and rotate towards the target, and I can go into any location in the spinal canal. So direction, depth transversus, get off, and then I am now very close. So there's never do I have what you guys are doing with interlaminar injections, in never knowing when you are in or when you are getting through the gap, because I can see it on the lateral view where we are. So could I do what you do? Hell yeah. But would I do it? No way. I would not go without knowing where the structures are. And the depth, by touching the bone, rotating, go to the edge, there's no vessels, nothing to hit, and then loss of resistance, and immediately switch over to the second stylet, and then rotate around and in the direction, and we're off to the races.
So what would you, in your opinion, be the safest lumbar level for doing your cervical lysis?
Safest?
Lumbar level. What level?
Lumbar, any
Safest.
level I have to be. I'm not worried about that. I don't worry about any level. But stimulators, I have to say that the distance in the upper lumbar area is much shorter. And that's where people get into trouble, where they go and loss of, they get a lot of wet taps. And the upper lumbar area is the problem. But there again, it's direction, depth, direction. You touch you touch the lamina, and then you go above. So you have to establish where there's no vessels, no nerves, to know where you are about to get into a dangerous area. So direction, 3D technique, direction, depth, direction is the name of the game. See you guys. We still have to do S. To improve radiculopathy, now we have studies by Park that 169 cases, 46 of them were recommended surgery for cervical neuroplasty. And only 3 of them went to surgery, but the main improvement came in a group where the flexion rotation allowed spreading of the local anesthetic hyaluronidase and hypertonic saline over the nerve roots. And that is what makes a difference. So movement of the needle and movement of the dura can only be possible if you don't put a sharp interface between the two. So either work through the tip of the needle or have a blunted second stylet before you have the electrode or the catheter in place. To improve radiculopathy.
Welcome
now
back.
We have studied.
So this concludes our morning session. So we're going to have a little bit of a break, and then this afternoon, Dr. Rácz will be back in the lab doing S1 and scarring triangle. we will have Dr. Fox joining us talking about licensing your private practice, and then we're going to do a little conclusion at the end. So if there were any questions you didn't get answered this morning, please join us. In about 20 minutes, for our US folks, we will be in the Americas Zoom room. Meredith George, who is our Director of Physician Services, will be joining and doing a lecture and answering questions regarding reimbursement. We know that a lot of you need a little break, stretch your legs, move around. We'll be back in about an hour, a little over an hour for this afternoon. We will be starting in about an hour and 5 minutes. On the half hour, we will be back, and that's when Dr. Rácz will be back in the lab doing S1 and scarring triangle. So if you need to get up, walk around, grab something to eat, please do so. For those of you, like I said, in the US, join Meredith George in the Zoom room of the Americas. And we look forward to seeing you this afternoon, this evening, this morning, whatever it may be for you. But we'll see you back in an hour and 5 minutes.
This Versacat I use for the for cervical. At the beginning I used Versacat. Now I'm using the other one, the XL Tunnel XL 24. Even for stenosis, cervical stenosis, and for herniated disc and cervical, I'm using it. Yes. For me, I've been very satisfied with using it in cervical because I don't know. It has been like the patient, come to my office with a lot of pain that you can see it's complicated with the pain, even sweating and cold, and because of this so severe pain. And for cervical and radicular pain, and the patient, and after the procedure, you can see like 1 or 2 days, and the patient start. I have a patient specifically that I did 8 years ago, and it was I think it was Easter week, and the patient came to me just before leaving Easter week for Easter week vacation, and the patient came to me like this, with her head turning at this side, because she couldn't put the hand down because the pain was so severe, and it was so amazing to see her MRI combine. If you combine the two images, MRI of C5, C6, C6, C7 with tomography, with scan. In the MRI, you just see like a protrusion of the right C5, C6 level, also a C6, C7. But when you see the CAT scanner, you can see that it was a spore, big spore. I told her immediately, I don't know, I think you must go to surgery. So she said, okay, I am diabetic, I have hypertension, and my son is getting married very soon, so I don't want to get a surgery. Please do something for me. And I think it was C67, because her tricep was so weak, and that was the only position she could sleep, and be like more comfortable. And she said, I can't stand this pain. This pain gets me crazy. I went to hospital, to the emergency room, so I can have a painkiller or something because it's so extreme. Please do something for me. Then I will go to a neurosurgeon and get a surgery. I started, I put her in a operating room, and I do the Rácz procedure and get to that level, C6, C7. And I have the 12 hours after that, 12 or 18 hours after that, put her hand totally in this position, trying a neurology, went to test, do the exploration, and how strength in the tricep just 18 hours after the I've done the procedure. And that was 8 years ago. And I said, okay, but you must go, because it's not like just putting a cage in in C67 or C56. It's a special procedure because you have a spore, a very big spore right there that's compressing the nerve and all the rest of the tissue. Surprisingly, I met with her daughter last year in a mall. So I say, oh, hello, okay. And I say, okay, how is your mother? Did she had the surgery? How is she doing? She didn't have surgery. What? No. With that procedure, it was perfect. She is okay. She has been doing great. I say, but she had a spore, a very big spore. I have the pictures and photos of her and everything. And it was amazing. It was amazing. So use cervical also and lumbar and, maybe, it swell and inflammation. And when you do the lysis and all this anti-inflammatory effect, then the root maybe like get a position, I don't know, like skip or dribbling, or I don't know how to say it, but it's something that happens and make the root go like, get a little space. I don't know after she will have any problems with that, but it was amazing. I have all the photos of the MRI, the CAT scan, the woman when she came to my like this, and then the neurology doing all this and she moving her neck. I also did on her some medial branch block also right here with put steroids right there too, because she had a lot of pain because she was like this a lot of time.
Welcome back to the second half of our virtual Rácz Lab Live. Hopefully you had a chance to go stretch your arms, stretch your legs, get something to drink, fill your tummy, and get ready for our afternoon session. Now, we've been online for a long time, and if you haven't refreshed your browser yet, you'll want to do that. So just hit that little circle at the top and refresh it over time when we have a video on for many hours. Sometimes you'll find that there's a little bit of a lag. So that should help you if you're having any issues right now. Just as a reminder, we will continue this ongoing education after the Rácz Lab. So first, for those of you who are online live now, you can go back and watch the video, or if you are just joining, you can go back and watch the earlier part of the program. So just log in, use your login, your password, get in all of that information, the videos that have been, we've been taping all day, and all of the supplemental information will be there. Starting in November, we will start an ongoing program where each month we'll do a little bit deeper dive into one section of lysis. We'll also have Dr. Rácz, who will join us once a month for an open house or just an open discussion where you can send in questions, ask him things about the articles and the topics that are discussed for that month. So if you haven't signed up for that, just go to raczlab.com and then just sign up for the monthly educational program. It is at no cost to you. So we are getting ready now to visit Dr. Rácz back in the lab. He is going to be doing S1 and the scarring triangle. So everybody get it ready and send your questions in, and we look forward to seeing Dr. Rácz. I'm going to go ahead and hand it over to him.
Well, welcome everybody back. This is something that is, I think it's one of the most exciting areas. Trying to line up the S1 ventral and lateral, ventral and dorsal neural foramina, and just playing with that. Keep going back. That separates it. Okay. Go back that way. Slowly under fluoro. Fluoro. Keep going. Now come back towards me. Now back towards the head. Back to you. Hold it there. Come. We had it for a second. I wonder, okay. It looks almost, I need to coalesce these two. Just tilt it up and down. Too much, the other way. Back the other way. Hold it there. Back a little. Hold it right there. I wonder if we'll do it, if that will do it. Well, interesting evolution of an idea. We had, I don't know, something like 344, it was a mixture of residents and fellows because I somehow got involved in pain and I needed help. And I had a ready source of help in the residence. So in the beginning, having the residents take some of the busy work like H&Ps and dictations and so when I declared them to be on the pain service for 6 months, I could do it because I was the professor and chairman. And some of them were very unhappy, only to discover later that was the best thing that ever happened to an awful lot of people. So that was the beginning. And I had to, in my residency and training, was like most people, you could put an epidural catheter in for 1 centimeter, never pull back. And that was the beginning. So we paid homage to the epidural space. And here we are now trying to figure out how the heck to rotate the C-arm to get into the S1 space. The idea I guess I would need, Gábor, could you put my thyroid shield came on. Picture. Now the question is going to be, which one is it going to be? Picture. It looks like that. Picture. 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 Well, anyway, something that we never really knew about and understood was the scarring triangle, as we later named it. In 2013, the German spine surgeons, the good number, like 5-6 spine surgeons, studied a space that is present in everybody. It's above the L5S1 disc, and it's in the ventral epidural space between L5 and S1 nerve roots. So it has absolutely nothing to do with the nerve root. The transforaminal discectomy approach doesn't get up there because they're looking at the disc, and this is higher up at the armpit of the L5 nerve root. And they studied it in cadavers and local anesthetic laminectomies, and injected it with silicone that hardens at body temperature. And they found that this was present in everybody. It's 0.9 to 1.1 ml. And the size of each of this space is big enough to accept the average loose fragment. And when they studied it and they came up with these findings, they did a great paper. It's published in the European Spine Journal, and the first author's name is Trescot, T-E-T-E-S-K-E. And we had a grand rounds presentation once a month by the fellows, and one of them presented it, and it just didn't sound right to me. That, but what they developed it into, to say that if you stick a needle in that spot where the this space is and inject a small volume, it goes a long way. And it communicates to all over the spinal canal. And they developed this spot as a way of injecting epidural steroids, so they've done thousands of cases with good results of injecting steroids. And it looked like God put it there just for German spine surgeons to inject steroids all over the place. But I really don't believe that, because God put it there to collect from all over the epidural space in that location. By having a space prepared for it, it doesn't compress nerves and just gets located, but then it becomes a dense scar forming, because nucleus pulposus that leaks out, it trickles down and goes into that spot and becomes a heavy scar former. And I've noticed it that when I came through the caudal epidural space, I could not get into this L5 area just above the sacrum, and it would be densely scarred down. And I tried to force my way, because I was always trying for the L5 nerve root, but this is separate from the nerve root. And then we noticed this mobility of the cervical epidural space, which we never ever understood that the dura moves. And the dura moves remarkably. If you looked at, you remember the video, might put it on during the discussion or the question answers. And that mobility actually could be transferred, and gradually over the thousands of cases I've done working in the epidural space, I realized that pain is where the dura is stuck down. Then we realized from Kozlich's work that the most painful structure in the spinal canal is the posterior longitudinal ligament. And we have had no way to test for it, and for some reason I started realizing that when patients have a leaky disc in the thoracic area, they will have a perfect location, and if you do a flexion of the cervical spine, you could actually aggravate the pain. And then we developed the idea of a dural tug, which will tell you, and then we realize the symptoms and signs that go hand in hand with that, and we'll cover that in a discussion. And so started making the diagnosis. And eventually, a few months ago, one of my patients that had no radiculopathy but had a very positive dural tug, and all he wanted to do play golf, and he couldn't because it hurt too bad. And then, having realized the pain coming from this sacral area, and it's not a SI joint pain, but when we did a dural tug, reproduced the pain. So we did the neuroplasty, and this is what I'm trying to say now. And he went home much, much better. And then he says, then he put his head in a certain flexion, he could reproduce the pain, so he kept doing the pulling on the pain, and after 2 or 3 days, this is following the neuroplasty through the S1, he reported that after 2-3 days of doing this many times a day, the pain all of a sudden left. Then he could go and take 10 days off and play golf, and he even scored a 78, which is pretty damn good for somebody who could not play golf for several years. But 10 days was sore from playing too much golf. So I'm trying to, if you think about the sacral S1 posterior neural foramen and the nerves going down and out, so that's the direction that you I wonder. So as we are looking with the C-arm, looking this way to trying to bring the ventral S1 neural foramen so they overlaps with the lateral, and we are going to try to get in at the medial side of the S1 foramen, starting about S2. Okay, picture. And our desire to overlap, so we'll see if we can picture. 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 Aha. Picture. It feels like maybe in lateral view. Remember this setting here. See, and we are, in fact, in the sacral canal picture. And our desire to get into the sacral canal is, there is a funnel-like S1 foramen, and we are aiming to the middle. The nerve is coming out laterally, and that's about the right spot. And now, when I rotate the picture, you see now we are heading picture, capillate, without being in the neural foramen. Okay, think again. Back to AP. You can't save it somewhere, can you? Can you save that picture? Okay. Go straight AP. So we are going through the dorsal or the posterior S1, and the ventral S1 is the nerve is coming down and going down out more lateral, and we'll see if we can get the catheter into this dense solid space when it scars down. Now, if you could tilt it, so save my fingers. See, we should be coming from S2, some bit of an angle from below. We'll see if this picture. That's going to burn me. I'm going to put my bend in. Just run my nail down and see if this will bend cephalad. Picture. And lo and behold, that's flaming perfect. You see it may be a little bit too high up. Picture. Picture. You see the picture. The location of the scarring triangle is just about here. Here comes L5, and it's between the S1 coming down and right this area. The bend in the needle directs it to go up. And for many of these cases, I've been coming more of an angle, and didn't matter what I was doing, it didn't go just straight away. It was going left, right, fiddling and x-raying my hands. And anyway, and when you inject it, I put in 10 cc's of Omnipaque, then it will start opening up, then go to the L5, then it's going up to, trying to go to the other side, but mainly the area that tends to be stuck down is the underside of L5 and S1, and those are the symptoms. You get pain in the hip. It may go down to the little toe. You get woody numbness in the L5 distribution on the lateral calf. Then there's an inability of the patients to elevate on painful side tiptoe, and or may just, the leg may just shake. But this is the technique, and you have to figure out that you have to get into the posterior S1 neural foramen. Just move a little bit down, and you want to see the catheter maybe a little bit more laterally. See if I can get a bit luckier. Picture? No, it's going more over to the right side, avoiding my getting to the other side. Picture? Anyway, this is fiddling time, and I've been x-rayed today probably more than I have for the rest of the year. Picture? Picture. Now it's heading in the right direction. Picture. Yeah, that's more like what I wanted. It's right in the S. Well, all I did was just move the needle a little bit. See, remember, we have quite a safe distance from the certainly L5, because that's coming up higher here, and the S1 continues and joins further in to help form the sciatic nerve, and S2 is also going with the sciatic, but 2 and 3 will go to the bladder. So when you scar down in this area, like I was just reviewing a patient I've seen this week, there's a shallow bulging disc of L5 and L4, and he had a very positive dural tug. That's when I set him up on the couch and sit up and bend as forward as much as he can, and then bend the head and neck down and move it a little bit to the left, a little bit to the chin to shoulder, left and right, and he reproduced the pain. He could not, I could not cause pain with straight leg raising. and he had just physical therapy and epidural steroids, and miserable. And it's amazing how common this is, except people just don't know about dural tug, and people don't know about dural flossing. Flossing is when you, like dental flossing, when you move up and move the head and neck and repeatedly on the spot where you find the pain. So that's dural flossing. It's going into the next chapter that we are writing right now. Just as a very brief, but we'll have the confirmations and we'll have the naysayers, but you have to suffer through that. Like one of my patients is the guy who introduced cardiac stents. And he says the biggest problem was the cardiac surgeons. Well, not so here, because it was the neurosurgeons that helped us to get the code for 62263 and 62264 was Lex Manchicanti. Lex is one of the greatest additions to our profession, and he's done tremendous work. But the first code was Sam Hassenbusch, who was sending me patients and even came to watch us do the procedures. But this is, I believe, to be the missing piece that we just didn't have the solution for. And I felt very badly for my patients that got 22 years relief from the first set and restarted the same area. I could not get into it, because when you look at it, let me show you again, you see that sort of comes above the disc, comes into this dimple here. Now if you go lateral view, yeah, lateral view, please. That should be in a ventral epidural space. Save that and picture. And you see, you remember I was in this same cadaver. I was trying to come up here, and the catheter ended up way posterior because of the curvature in the sacrum, coming from the sacral hiatus. And here I'm coming down, we're right on bone, and curving up so that it doesn't spray over to the right. We cross the disc space, and we are in the dimple. So this is an area that we could not access before. And I was trying to explain maybe it's an aberration of the sacral anatomy, because sacral anatomy is the most aberrant bone in the body. So many variations. But it looks like we're getting a bit better and better and closer to the truth. Anyway, so we go and put in 10 cc Omnipaque 240, 10 cc hyaluronidase, 150 units of the recombinant hyalgan product, and one of the questions about the enzyme being put into the patient's body is, in the beginning when I learned about this about 25 years ago from John Lloyd in Oxford in England, and I had to do a skin test every time before we did it. And there was one paper that referenced Danny Moore, and he had like 1,300 epidurals, so he tried to spread it out further with hyaluronidase. And he said something absolutely hideous, that there was a 3% anaphylactic reaction, and therefore we did the skin testing. And we never ever saw a positive skin test. Then I was invited to the American Society of Ophthalmic Anesthesiologists, and I thought, here's my chance. So there were about 300 or 400 doctors, and so I said, how many of you use hyaluronidase? They all raised their hand. And how many of you have seen anaphylactic reaction? Nobody. How many of you do skin tests? Nobody. So since then we started paying attention, and only to discover that nobody recommends doing skin tests. Nowhere is there a recommendation. The FDA does not recommend it because it's somehow it just doesn't seem to happen. And maybe the standard of care in the 50s was higher mortality from anesthesia. We didn't have the modern anesthetic, so I don't know what Danny Moore, because I knew Danny Moore quite well. So don't know what he was talking about, because so far I have seen anaphylactic reaction to nickel, to retractors in the steel, and I've seen anaphylactic reaction to penicillin and to the point of ventricular tachycardia. But both of those patients I was able to send back home without bending a hair. But I'm a bit verbose on this because you need to know where we stand, and we did the most referenced article on hyaluronidase because we looked at the approved and non-approved uses of action, and we updated it with Dr. Hebner, and we did another review with Stenhelm on hyaluronidase. So I would say we are pretty well up to date on the topic, and it is remarkably safe, and it makes a huge difference in that it prevents edema formation after a neuroplasty. A neuroplasty can cause edema by separating tissue planes, and hyaluronidase has been for many years now routinely used, and we just don't see problems. And I feel that my patients are served better, and I totally disagree with when Steve Cohen says it only adds to cost and complications when they had reported 0 complications in the article, which was a review of, but they did say that 5% hypertonic saline has a shorter duration action than 10% sodium chloride. So I believe the 10% sodium chloride is appropriate. And now you can do pain-free hypertonic saline injection, which had been an incredible problem. And we solved it sort of by spreading the pain out by infusing it over 15, 20 minutes. And but I can't make this any more complicated other than remember, just give us a picture of the whole sacrum and look at the curvature in the sacrum to appreciate just a little bit further south. And if you could block off some of the white because you're missing the curve. You see, S1 is here, and the sacrum curves down. And when you come in from here, the natural tendency is for the catheter to continue instead of diving down where we have to be. And that's why we cannot do this to the ventral epidural space. You can by curving the catheter, but when it becomes difficult, that is because there is scar formation, and it's very rigid scar. Now, you cannot get a regular catheter into this scar formation. And that observation belongs to Tomikichi Matsumoto. He came through S1 with an 18-gauge RX 2-kude. And remember, don't move the needle without the second stylet. It's a little bit of a delay and time-consuming, but it can cut dura and vessels and nerves. And you have to be safe on the relevant safety. And I almost at a point where I think you would have to ask the patient for a consent form to use a hazardous sharp needle in anywhere around about the spine. Just too darn many injured patients from sharp needle related injections. Anyway, this is, I think that's a good picture. It makes the point very well why we are really in need to go up to the S1 to do this, and how elegant that is to separate the S1 nerve from the tip of the needle when you put it in. And any movement of the needle should be with the second stylet. Well, I think we made the point. I struggled a little bit, and all I can say is that there is a concept, I have a few more minutes, a concept that if you pull on a vessel, and there's an entity called traction spasm. And the traction, if you pull on the nerve with the vasa nervorum, they can go into spasm. So it's not a dead nerve from the spasm, but it's an ischemic nerve. And the motor function of the nerve is less potent. And if you think about the nerves, when you have a surgical laminectomy, there is a 500, I think it's 530 or thereabout case series of orthopedic unroofing of spinal stenosis, and the finding was surprising in that there was a 26% bladder dysfunction following in the observation period. And I had one VIP lady, a mother of a significant person, was sent to me. I looked at it, and we were going to do for spinal stenosis neuroplasty, lysis, and a transforaminal at the level of the spinal stenosis. That's the best outcome. And the patient, when it's time to do the procedure, started the ambulance driving to our hospital, and instead of went to an across the street hospital and see a neurosurgeon who did a decompressive laminectomy, and post-procedure could not void. And when she couldn't void, she had to self-catheterize. So this 80-some years old lady, having to catheterize herself 2-3 times a day, and eventually, after 3 months of doing this, she came to see me, and so I did a caudal neuroplasty. We did not know about the scarring triangle of Trescot, and after the neuroplasty, I must have opened up the sacral nerve roots that get gummed down and just bogged down, and the spasm disappeared. Next morning, she voided, and she voided thereafter. So once you free up the nerves with the S1 transforaminal neuroplasty, since then I had recently where I had to go back twice, and the second time I went back was 6 weeks later, but she had a weakness and not very heavily complained because she didn't think we could do anything, but then realized that she was getting up 15 to 20 times a night to void, and that's misery. That means you are dead beat all day long. You never sleep. So she had some additional pain from the other side, so I had to go make a decision when you go back. And I for years I thought I should not go back earlier than 3 months, but I believe that was in error, because the reason was I didn't want to end up doing too many procedures, and but we lost the softening of the scar tissue by the hypertonic saline. Berkemeyer is the guy who did wonderful studies showing the effect of hypertonic saline, and 10% is the most effective, and it is it has inhibition of fibroblasts, and it's a profound inhibition, and it looks like this is like surgical scarring, but round about 2 to 3 months the scar tissues really are firming up and getting more and more involved. So I went in at 6 weeks, and after the second injection, so we do the first injection with 0.25% marking, second injection with 1/8%, third injection 1/8%, the hyaluronidase, and we did the pain-free hypertonic 1.5 cc in the caudal, 1 cc, and 5 cc increments, 5, 5, 5, 5 in the transforaminal. And after the first day, 2 injections, and the second time, she says, I slept all night. And this has been several months ago, and to this day she is not getting up at night. So I believe that when you run into this bladder dysfunction, frequency, inability to void, this is phenomenally effective. I need to confirm or disprove, but need to do the procedure right. So we should have come in at a little bit lower than L2 and then rotate around and point it up. Now I thank you for your attention. I have used all my time, and I believe this is a story at least you have now seen more in detail. But isn't that beautiful? Beautiful.
I had one question.
Yes, yes.
So, what is your rule in, rule out criteria for this procedure in the setting of a spinal stenosis case, rather than minimally invasive open procedure?
Minimally invasive.
Open procedure.
Oh, it's a patient decision.
No, they can hear you.
It's a patient's decision, but the case report in the second edition of Techniques of Neurolysis outlines your options. The patient is a very extreme VIP and had a surgical laminectomy at L345, had 5 years of excellent pain relief. And then pain came back because now had spinal stenosis at L2, 3 level. And he was stable, had no instability. And I went in, a caudal, transforaminal, and at 5.5 years, the pain came back, but not where I did the neuroplasty. The neuroplasty was wider open than the surgical opening. It came back because now he stenosed down L1-2. So I came in caudal, now this time S1, transforaminal, and he's doing very well, but had an L4-5 in the middle of the surgical unroofing section, a facet cyst, a huge facet cyst that grew in the 4-5 area, severe pain. I went in with an 18-gauge RX2 needle and got the tip of the needle of the 18-gauge I can into a facet and pushed it across. You can rotate it, it will find it. and then we just ruptured the cyst, and he's been doing ever so well. Now we have a ability to compare, and it's out for the whole world to see that the surgery was outlasted in how much it is opened up in the neuroplasty versus 3-level opening. And he's an athletic, wonderful, 80+ years old now, and you wish you could be as active as this gentleman is. But it's in techniques of neurolysis, and the problem with surgery in a disease that is progressive, that you have a chance for progressively forming scar tissues, disrupting other levels, pain can come on the other side, and we can go in and open up this area, that area, but there's no guarantee any procedure can give stability forever, but it's virtually, so far, no major disasters that I would have had in all these years, including in many, many countries that I have proceeded, and I felt I had a built-in immunity that, I don't know, maybe it's just persistent luck, or it's God's design that I should be allowed to do that. So I think that's a very lengthy, but I would, if it's me, looking at my daughter, looking at dear friends, and they would, no way would choose surgery. But surgery, I find that it's instability, and it's badly needed when I know need surgery. I accept the family's decision, I accept the patient's decisions, and it's been blocked in different areas, but it's an amazing procedure.
Everyone here at Epimed works very hard and very diligently in order to produce the utmost quality product. Everybody has more of a piece of themselves in the company. I've worked at a couple other bigger companies in my past, and I find that Epimed is a much better place to work. You are a person here. You're not just another number on board.
I want to talk about the examination of FIPP. How do you keep up your knowledge? Continuous learning, ongoing accreditation is necessary to keep your title as pain physician. Together with Peter Staats, we want to improve our FIPP exam. So we did a survey. They said it improved their patient safety. It improved their knowledge and skills. It improved their careers. And we always will improve our exam. Thank you for your attention.
Here's what's really good about the Epimed lead vest, is that you can have a wide variety of shapes and sizes, but most importantly, you can get material that is lead equivalent and that is ultralight. So what I'm talking about is 0.25 would be the actual thickness of the lead equivalent, but what that does is that really reduces the weight. So when we're talking about being in these procedures from 8 to 10 hours a day on a daily basis, our posture becomes pretty important and we just start to get tired over time. So when you wear a one piece, a single heavy lead, it's eventually going to start to pull down on your shoulders. It's going to affect your posture. Eventually, you might be the individual coming in for a pain procedure. So what I really like about the Epimed vest here is that we have the ability to get a skirt and a vest so we can distribute the weight. And I can also have the ultralight material, the 0.25 material that I spoke about. So I still ensure the maximum amount of protection, and I am easy to take it easy on my body as well with the actual weight being distributed. A two-piece vest is very important for distribution of weight, because if you can imagine, so you're really just kind of having a half piece. So you put that half piece on, and then you wrap a skirt around. So when we go with this one piece, it's basically going all the way down, pretty much mid-thigh, anywhere to the knee. So it's all of that weight with that lead portion in front of you that's eventually just kind of pulling you down, right? But when you have just that two-piece, you're able to really distribute that weight and you can really balance between upper and lower torso. The pain management industry it's a growing field. Whether you're working with pain management trained anesthesiologists, whether you're working with PM&R, there's a whole subset of classes in medicine that are using fluoroscopy and they're treating pain management procedures. And so what you have is when you don't have a national protocol or a way to educate individuals, you kind of get a lot of different stories and not everybody actually knows what's the best mode of operation. So what I really see here is really a need to kind of circle back and re-educate whether staff, providers, administrators, the whole gamut of the healthcare profession to really understand how important it is to protect yourself from radiation, specifically when you're exposed to it on a daily basis. And ultimately, if something detrimental was to happen to one of our employees because we weren't taking the proper radiation steps, that ultimately is going to lead to a loss of an employee. It could lead to a potential lawsuit. It's going to force you to hunt for new employees. Either way you look at it, it's not good. There's always going to be some form of a problem, basically, by not taking care of yourself properly. And so it's really all about education, and it's really about knowing the damages of the effects of this ionizing radiation to your health long term. And I believe if more individuals have seen some of the effects and know the risks involved, that you would see a movement in individuals trying to protect themselves a lot more than they currently do. There's certain things in business or life that they have to go with, you just need. So when you start a pain practice or you have a fluoro room or an x-ray room, lead goes with it. That's all there is to it. So what you want to do is you want to kind of run a equation in your head. How many individuals will be in my room when I'm doing my procedure? You'll most likely have an RN or a medical assistant, possibly an anesthesiologist, and obviously the doctor. So it's pretty safe to say that you should have a minimum of 4 pieces of lead. That's going to want to come with thyroids. It's going to want to come with eyewear, of course, as well. So now from that standpoint, you'd also want to think, well, what if we might have another member in the room? Will there ever be a rep in the room? Will there be a consultant in the room? So really what you need to do is, if you don't want to protect yourself, fair enough. You're going to have to protect other individuals who come into the room. It's essential to have a proper amount of radiation protection. You should be completely aware of the vital organs that can be damaged by this ionizing radiation. You should protect your eyes, you should protect your thyroid, you should protect your vital organs. You should be conscientious of patients who come into your procedure room who might be of childbearing ages, and we should definitely want to protect them as much as possible as well. So radiation protection, unfortunately, is a pretty important thing to what we do here. There's a cost associated with it, and it's one of these intangible things that you can't quite quantify and put your hand on. But long-term down the road, if you didn't do your due diligence, you'd know why.
Well, we have a real treat for you now. Next up, we have Dr. Ira Fox, and he's going to talk about lysis in private practice. And if everyone should know about lysis in private practice, it would be Dr. Fox. He has done more than 13,000 lysis procedures. He's also been elected America's top physician by the Pain Management Consumers Research Council of America. He's been a top doctor in Broward County for the past 10 years straight. He's published exclusively, and he has and he lectures internationally. He's been on numerous media appearances, and he is just a true contributor to pain management. So happy and honored to be able to introduce Dr. Ira Fox.
Okay. Hi, Dr. Ira Fox here, Coral Springs, Florida. And I understand you'll be seeing my my presentation from can you hear me? Okay. Sorry for the technical difficulties. But I understand you'll be seeing my presentation on the lysis of adhesions, Rácz procedure. And that was done, I believe, in October. Our practice had done approximately 13,000 of those procedures with excellent results. We continue to do them. And I'm proud to say that since that time, my practice has seen over 100,000 new patients in our practice. We saw patient 100,000 this year. We're quite a bit over that. I think we're at 103,000. And the reason I mention that is because I think the lysis of adhesions procedure has been an important part of our regimen in treating chronic pain patients, especially those patients who've not had adequate responses from epidural injections, particularly transforaminal. We don't do interlaminar epidural injections. And you'll see in the presentation, I give a lot of reasons why that is. So I hope you enjoy the presentation, and I'm going to be available, I understand, afterwards to answer some questions. But this procedure has been a very important part of what we've been doing for the last 25 years here at Anesthesia Pain Care Consultants. So enjoy the presentation, and I look forward to your questions after.
How many people here are doing lysis of adhesions procedure? Okay, perfect. How many people want to do the lysis of adhesions procedure? How many people want to be great at it? Yeah. So I will tell you that it's been a very important part of my practice. I think it's a very necessary and underestimated procedure for a lot of different reasons. That's where I work. That's my office, our home building. As I like to tell people, my office is right there for a reason, because I like to see my patients coming in and out of the building in the parking lot. It's very interesting. You know, on the way out, they take their walker or wheelchair and they throw it into the car and they're walking. And they got the script in their hand, you know. They're so happy. One way or another, they're happy. They're either better or they got what they wanted. But I think you can learn a lot about a patient watching them come in and out of the building. So at our practice, we've done lysis of adhesions a few times, 13,743 times. That's when we started counting in 1996. We've probably done more than that. And we've actually done quite a few transforaminal injections. I think it's a pretty interesting ratio there, and I'll get into that in a moment. We've also combined lysis of adhesions with transforaminals. Believe it or not, Medicare used to be okay with that and pay for that years ago, and then they said it's one or the other. Sometimes we'll do it anyway because I think it's important. And then, of course, you can be doing double catheters, which I don't have that data up there, but that's basically going to be a transforaminal approach along with a caudal catheter. But one of the interesting things is we obviously do more transforaminal injections because a lot of times they work. But what do you do when they don't work? How many people here do transforaminal injections? So what do you do when they don't work? And it's a radicular problem. It's clearly nerve root related. What do you do? Anybody? Okay, I'll show you what some people do. So let's do a clinical case real fast. This is a patient that everybody has seen. It's a 24-year-old male with a history of a work-related lifting injury. He complains of pain in his right lower back, buttocks, posterior lateral thigh, and leg, with numbness and weakness in the right lower extremity. MRI shows a L4-5 disc herniation. Physical exam is consistent with the lumbar radiculopathy. This is a very, very common case. Everybody's seen this patient, right? And of course, you know, you go through the conservative measures, physical therapy gets temporary relief. But here's what I want you to take away, and here's what's so important about what I'm about to tell you. Temporary relief from interlaminar and transforaminal epidural steroids. Now what do you do? That's a really important part of understanding how important this procedure is. So temporary relief from lumbar epidural steroids. Let's go on and see what happens to this type of a patient very frequently. Patient's directed for surgery evaluation and undergoes a discogram, which is positive. Of course it's positive. Seen in a surgical reevaluation and deemed to be a surgical candidate for discectomy. 6 months later, undergoes a spinal fusion surgery. 1 year later, he continues to have severe pain and unable to work and becomes permanently and totally disabled. Happens all the time. So if you're doing interventional pain medicine and you have these cases and it doesn't bother you, then something's not right, because I find that very troubling. And then people end up like this sometimes, you know. And so there's a book in Florida. Dr. Lipnick probably knows about it, because when you get a rejection from a workers' comp carrier on a procedure that you want to do, they say it's not authorized. They use this book. And it's actually an amazing book. It's got a tremendous amount of information in there, but the insurance companies like to use it when it's to their benefit. So it's a little bit inappropriate sometimes, but what I want to show you about this book is a quotation about the lysis of adhesions procedure, Rácz procedure. This is a direct quote. There's a large amount of variability in the technique used, and the technical ability of the physician appears to play a large role in the success of the procedure. Wow. Wow, right there in the book.
And that's so awesome because if you learn how to do this procedure right, it works. If you say you did the procedure, but it really wasn't the best technique, it may or may not work. And isn't that true for a lot of the things we do? And that's what makes our specialty so challenging, because everyone's looking for evidence-based medicine. Well, I guarantee you, if everybody in here did the same procedure, we may get 10 or 15 different results. And the same thing holds true for this procedure. It's very technique related. And at least there was one thing in that book that I got to really pull out and use. Then he went into the evidence, which we all know there's level 1, 2, 3, and 4, and summary of evidence in the ODG guidelines is moderate for short-term relief and long-term relief with repeat interventions. But we'll talk about more evidence and research, and now you have Dr. Gerdes-Meyer's study from 10 years ago following up on people who are still better. And I can tell you, I have patients that I've done this procedure on 20 plus years ago that are still better. Many, many. They come back to me for different problems. I get an MRI and the area that I treated is better, or they have a completely different pain. So, you know, when you're looking at studies, and I have some to show you, you can look at it in many different ways. So what are the objectives of a caudal epidural neuroplasty? Well, we're treating patients with chronic lumbar pain with and without radiculopathy. And how does it work? Well, some people think it's a mechanical breaking up of the adhesions. It's not. Dr. Rácz will tell you that all the time. There were studies that actually proved that not to be the case. Having said all that, I still think that it helps mechanically, but it's not the sole purpose of the procedure, and that's not what is causing the lysis of adhesions. So the fluid volume with hyaluronidase further helps break down the scarring. As Dr. Rácz mentioned last night, you know, the liquid finds its own path and will help separate the nerve tissue from the adhesions. Corticosteroid is used as an anti-inflammatory. There's an osmotic reduction of edema with the hypertonic saline, which also has a local anesthetic effect. It's not neurolytic. And there's also the local anesthetic blockade of nociceptive information to the brain. Lesion specificity, probably the most important thing of all. You got to know where your patient's pain is. Otherwise, you're like a surgeon. You're just treating the MRI. It's just so amazing sometimes how a patient will have a very clear description of their pain that matches up in your mind to a particular dermatome, but then the MRI shows a problem at another level, and then they get surgery somewhere else and they come to you, they're still in pain. So you got to know where the pain is. I think that, to me, that's more important than any other finding as far as deciding how to treat patients. And then combine the information you receive from the patient with the MRI studies and the epidurography for the best results. So you're going to combine what the patient's telling you, what you see on the MRI, your physical exam, and then the epidurogram. Remember, I showed you we do a lot more transforaminals than we did lysis because I like to see what I'm looking at with the epidurogram. It helps me understand whether there's adhesions there or not, especially in virgin backs. We're going to talk about that. And then you want to identify that specific target for needle catheter placement. You know, when I talk about epidurograms, I could walk into one of my doctor's ORs, he's doing a procedure, and I see an epidurogram up on the screen. I can tell you where that patient's pain is just by looking in there for 1 second, because I see where the contrast is not going. And that's a very fundamental, important understanding of this procedure. When you're looking at epidurograms, especially the laterals, you want to see where the contrast is not going and ask yourself, why is it not going there? Well, maybe there's some adhesions, some scarring from inflammation over a long period of time. Well, why is that happening? And is that a reason for the patient's pain? And I can tell you,
if you look at that as a next step, rather than what happened to this workers' comp patient who ended up with a fusion and permanently disabled, you're gonna save a lot of cases. Yeah, I do monitored anesthesia care on, well, I do it on everything. All my patients get sedated because I'm very busy and I go from one operating room to another, and I don't really like to hear patients complain and, you know, they're screaming and carrying on. That's not for me. So all my patients are comfortable, they're very happy, and they're very happy to come back. And by the way, a couple of other really important things about sedation. And first of all, let me say this. There's sedation and there's general anesthesia. So I'm not talking about general anesthesia. That's not what we're doing. We're just keeping patients comfortable so that they don't remember it as the worst experience they ever had. Because if they do remember it as the worst experience they ever had, and they don't get better, they're gonna come back to you and they're gonna say, "Doctor, did everything go okay in that procedure?" "Yeah, why?" "I remember this pain during the procedure, and now I think I'm worse than I was before. Are you sure everything went okay during that procedure?" I said, "You don't want that problem." So I like to sedate my patients. It's a pleasant experience. It didn't hurt. I numb it up real nice, and that's my own personal preference. I respect everybody for how they want to go about this, but I like to do MAC. And again, patients must be responsive, but they're comfortable. So Dr. Rácz used these slides last night. As you see, we'll spend a couple of minutes on the technique just to review the caudal approach, which, by the way, he said a very interesting thing last night as well, how some people struggle getting the caudal needle in. I got to tell you, the Rácz Coude needle really makes it easy with that little curve on it. But my trick is I always start off in the lateral projection. And, you know, I feel the landmarks, and then I'll use a 25 gauge needle with some lidocaine ready to inject in the area that I think is appropriate. Shoot the lateral image, and you can see where the entry point is. And then I already know from that point, I put the local in, I already know where my Coude needle needs to go. So it's kind of like a scout film with the 25 gauge needle, which doesn't really hurt much. And I use that as a means to start. And then, of course, we are looking for the ventrolateral areas where the nerve root exits the foramen. That's the sweet spot. And we're going to spend a lot of time on that. If you're doing a transforaminal catheter, that will be the entry point. And if you walk away with just one, I'll say two things today, this is certainly one of them. You got to have that catheter in the ventrolateral space for the best results. A posterior placement will not reach the pathology. So, here's an epidurogram. You see the posterior epidural space and the ventral epidural space. The epidural space is cylindrical, it's round, right? Interlaminar injections rarely work because when your needle comes in posteriorly, your contrast and your medication stays posteriorly, very often. That's why interlaminar injections are not anything that I do anymore. You got to get in here. You got to get ventrally. This is where the nerve root's coming out. In fact, here you can see a little bit of L4, and there's a little bit of L5 coming out. But these are the spots that you need to be at. If you're not getting contrast or medication to those spots, it's not going to work. So, I put a little bend on the catheter, and I'm going to give you a pearl. Because, how many people are in here anesthesiologists?
Okay. So how many people have done epidural catheters? Okay. So as an anesthesiologist, even blindly, labor and delivery, whatever, you can get in 1 second, you throw the catheter up there, and I'm so great. Look, it only took me 1 minute, okay? But when you do that in this procedure, and you start feeding that catheter up quickly, what can happen is it hits the adhesions and it bounces off. And you get very frustrated. You're going, oh, man, I can't get there, I can't get there. You can get there. You need a different approach, a different technique. Move slowly and deliberately. It's different than a labor epidural. You got your bend, you're heading towards the target. If it bounces off the adhesions and it doesn't want to get to the spot you want, keep your line and move so slowly that you almost don't even see it moving. And when you do that, all of a sudden this catheter starts to keep the line and it burrows through the adhesions and you'll get to your target. But if you just try and do it faster or force it, you're not going to get there. It just deflects off. So this is a very important pearl for you to have. You want to stay lateral, and it may require multiple attempts while mechanical adhesiolysis is achieved. As I told you, that's not true. It's not mechanical. But it may take multiple attempts to mechanically get to the spot you want. That's a better way of wording that. So you got to differentiate between fibrosis patterns, sequestration, and loculation. As Dr. Rácz spoke about last night, if you're having loculation, that contrast just isn't going anywhere. You're creating a lot of pressure in the spine, and that's going to subject you to complications. I'm not going to spend a lot of time, but it's important that I explain to you the bupivacaine that you're injecting is your insurance policy. It's your insurance policy that when you see the patient a half an hour, as you know, 0.25% bupivacaine does not cause motor block. If you wait that half hour and you go to the recovery room and the patient can't move and they have a motor block, you know that that medication has either gone subarachnoid or subdural, but that patient's not a candidate for hypertonic saline. So it's imperative to check patients for motor or sensory block in the recovery room. You got to wait that half an hour. If you're using hypertonic saline, you must wait and see what happens before you go ahead and give it. So, and if they have no motor block or significant sensory loss, we'll infuse the preservative-free hypertonic saline. Transforaminally, I typically will only give like 1 ml if you're in the foramen. And I determine the amount of hypertonic saline according to the extent of the stenosis and the fibrosis. If you see that patient's got a really tight area, you're going to cut your volumes down. It's a judgment. You know, typically we'll give more depending on how it spreads when we did the epidurogram, and we'll give less otherwise. Double catheter technique allows for transforaminal lysis at a more cephalad levels. When you're up at L2, L3, it's not easy to get that catheter up from a caudal approach. So the transforaminal approach can be very helpful in those situations. And it also provides an opportunity for additional hypertonic saline laterally at lesion sites and fibrosis. And there's a picture of the transforaminal needle, the coude, which is turned and catheter is placed. There's a picture of how it looks under fluoroscopy. This is a typical Florida spine, by the way. There's no discs. You know, there's scoliosis, and we see this a lot. Now, what I'm trying to show you here is not how messed up the spine is, but how that catheter is actually accessing the ventral epidural space. That's where you want to
So these are enhanced techniques for the lysis of adhesions, where we can also combine transforaminal epidural injections with caudal catheter neuroplasties, so you can get additional medication to nerve roots distally and access the nerve root sleeve and ventral epidural space, especially at higher levels. You can get better multi-level delivery of steroid to complex areas of lateral recess stenosis. And there's also a vascular runoff. You know, when you have high pressures within the epidural space as you're injecting contrast, you can see that you're not intravascular, but as you're injecting more and more contrast, you can see some of the contrast being taken up by small vessels. That's called vascular runoff. And a lot of times, if you do a transforaminal at the same time, that will eliminate that problem by releasing some of the pressures. Now, here's the meat. How many people can do this? L4, L5, S1, multi-level transforaminals. How many people can do this? Easy, right? Okay. So you've all seen this picture, and you walk away and you go, perfect. I'm going to show you why this is not perfect. Because that's your lateral, and there's your contrast in the lateral position. You can see the nerve root coming out distally, but the ventral epidural space has no contrast in it. This is where your adhesions are, all along up in there. And this is a nice spine. I mean, look at these nice, fat, juicy discs. So this is the type of case where you're going to say the patient had a transforaminal injection, didn't get better, and now what? Okay, I'm coming back to the beginning of our discussion. Now what? What do? I'll tell you what you do. Some people may do facet injections, because you can have radicular type symptoms from facet injections. Some people try SI joint. I see that all the time. And a lot of people are going to send them to the surgeon, especially if the patient came from a surgeon. Well, I don't do that. I'm going to do a lysis of adhesions procedure, because unless I see a perfect opening up of that ventral epidural space, I'm not satisfied in my mind that the medication got there. If the medication didn't get there, how can you say it didn't work? Okay? You see, there's only two reasons in the whole world why a procedure doesn't work. One, medication never got there. It's not going to work. Two, pain's not coming from there. Okay? Because if you get medication into the area, you should get some relief, a day, 2 days, you know, something. If you get no relief at all, and your medication's there, pain's not coming from there. And that's even a worse candidate for surgery. That's even worse. Those patients are never going to get better. They're going to get permanently and totally disabled. Possibly, as in that case I showed you. Remember, it's a ventral epidural space. The epidural space is cylindrical, it's round. You got to have it looking like that, or close to it. So what we did was we brought a catheter over to the foramen. Now, if the epidural space is cylindrical and round, visualize in your mind, as you go more lateral, you're going more anterior. Okay? Vision the circular anatomy of an epidural space. Well, you can't go through there that way, so you're going more lateral. As you go more lateral, you're going to get more anterior, more ventral. That's a very important concept. That's the second most important thing I wanted to let you know about today. So we were able to go there, and you can see the L5 nerve root coming out quite nicely. And this is the same patient. Now you see the ventral epidural space completely opened up. You see access to the nerve root in the lateral image.
If you don't see that, you haven't really told me that the medication has reached the target area. The title of this lecture was supposed to be target specific, so that's what they mean by that. That's target specific there. Because if we go back, that's what it was before, okay? And that's what it is now. So if I do that and the patient comes back and says, I'm not any better, at least I could sleep at night. I know that, you know, I did everything I could to medicate that area, and now I'm going to start to wonder, wow, this patient really looks like he has an L5 radiculopathy, but maybe it's something else. Maybe. And then I'll have to go through a treatment algorithm to prove to myself either it's something else or it's not. But clearly, a lot of these patients are going to respond now. So, this is the beautiful part. How many people here treat a patient a couple of times and then they don't come back, so you assume that they're better, right? Yeah. They're not necessarily better. They may be in my office down the road telling me that it didn't help, okay? And then I'm going to do this, and they say, wow, I've had epidurals before, but I never had anything like that. That's why you're here today, okay? That's why you should be excited about doing this procedure, because there are reasons. These are the reasons. And, you know, I have a problem with it, you know. Oh, I had epidurals, it never worked. Do you have the pictures? No, they don't save them. Do you have the pictures? Oh, I don't know. Do you know who did their procedure? I don't remember, but I know epidurals never worked. You try this first, and then you move on from there. So here's another great Florida spine. Could barely get over. Now, but you do still see the nerve roots come out. Now, what's better if you can't get laterally at the level you want, if you had to choose? Are you better off getting laterally slightly below, or are you better off getting to the level you want in the midline? That's like really bad choices. But you're better off being laterally, even if you're a little bit lower than where you want to be, than you are at the midline. I could tell you right now, putting that catheter at the level you want at the midline is not going to work most of the time. And that brings up another can of worms. Many patients who I know have had this procedure done, and I do get to see the pictures. The catheter is midline at the level, said it didn't work. It didn't work because your technique wasn't doing what we just spoke about. But even so, we were able to open up the ventral epidural space in this horrible spine. This patient could have been over 100 years old. I don't remember. Okay, here's more L5, nerve root, way lateral. So what are the complications? They're very rare. Subarachnoid or subdural injection, local anesthetic, temporary effect. As long as you're detecting what's happening, you're safe. You know, if you had a dural puncture or you suspect a subdural spread of contrast, you know what's happening, you can deal with the issue. Dr. Rácz brought up a great case where you can go in there and suck out some of the contrast. I've never had to do that. I have had a couple of contrast spreads that I wasn't happy with, but the patient really wasn't complaining. I watched them very closely. I brought them back another day. Live to fight another day. There are people who will, you know, try and move on the same day. They'll, you know, replace the catheter, come back to a different spot. I just bring them back the next day,
the next time, whether it be the next day or a week or two later, whatever it is, and then try it again. But I will say, it's very, very rare. I could probably in over 20 years count less than on one hand, okay? So it's not gonna happen. And certainly the really devastating potential complications that we think about, I've never had one. So subarachnoid hypertonic saline, cardiac arrhythmias, paresis, loss of sphincter control. Cardiac arrhythmias, as Dr. Rácz spoke about last night, Hitchcock was doing these intrathecally with saline, and but you know, you just got to know what you're looking at. If you're not sure, you know, you stop there. No one's going to get into trouble with a little bit of contrast in a place that you didn't want to be. That's not how it happens. So as long as you can recognize those patterns, I can tell you out of all those cases we've done, we've not had this problem. And what happens is you compress a spinal cord, and you basically are having complications as it relates to the increased pressure. So you want to inject slowly. You want to assess the degrees of stenosis when you decide on the volumes. You want to see how tight it is. Sometimes you may just need 1 or 2 cc's, you know, may be enough. And again, you want to distinguish between sequestration of contrast and loculation. Sequestration of contrast means the contrast isn't spreading to the area that needs it. Loculation means it's just locked in there, and now you're injecting and it's getting harder and harder to inject. You don't want to do that. A lot of this is common sense. Okay, complications, paralysis, bowel, bladder dysfunction, infection, catheter shearing. Interestingly enough, we're discovering cases of bladder dysfunction that are actually getting better with lysis of adhesions in the scarring triangle or the lower L5-S1 area. I'm going to do this real fast because this is just a pet project of mine, my own clinical experience. But you know, when you see patients with lower back pain, it's very tempting to immediately think sacroiliac joint, because that's where the pain is, you know, that's where they're pointing to. But the sacroiliac joint is in what I call the high traffic area. It's the size of a silver dollar. You have the L5 nerve root, you have the sacroiliac joint, you have the L5-S1 facet. They're all right there. So they're pushing on the back. Does that hurt? Yeah. Oh, it's sacroiliac joint. You know, it could be any one of those 3 things. So what I want to tell you is, think about L5. High traffic area includes the SI joint itself, as well as the L5 nerve root, L5-S1 disc, L5-S1 facet joint. It's all right there. There's no way you as a clinician could tell me what it is by palpating someone's back. It's not possible. So I started thinking about L5 because the referral pain patterns with SI joint are very similar to the L5 radicular pain patterns. When you look at the published pain patterns of SI joint, a lot of them resemble what could be an L5. That's kind of what got me started on this. There's the SI, there's the high traffic area that I'm talking about there. So there's really no good diagnosis for it. The maximal pain is below L5, but it can go to the entire lower extremity. 94% have buttock pain, 48% thigh pain, 28% lower leg pain. That's for SI joint. That's Dr. Fortin. This was published in Spine 1994. So the best screening test was pointing to the posterior iliac spine. This was Dreyfus, 60%. Provocation tests are informative but rarely diagnostic. Laslet, imaging, not diagnostic. So there's no real way to diagnose SI joint. Local anesthetic blocks can give false positives. Here's the arthrogram of an SI joint. And this is what I want to show you. This is a lateral image of the arthrogram. There's the L5S1 disc, and the L5 nerve root runs right down there. And in fact, sometimes when you do transforaminal injections, you can see the contrast. If there's some stenosis there at the foramen, it'll run all the way down right on that SI joint area that you're palpating. So I decided, oh, here's another one. Runs right down there. So I decided maybe this painful palpation is referred pressure onto an L5 nerve root with inflammation distally and not the SI joint itself. Again, here's another one, transforaminal injection. I started seeing a lot of these over the years, you know, people with stenosis. That contrast just comes out and it's running right down there and it's coming off the L5 nerve root. So if you can't figure it out when all else fails, try doing this. Put a catheter up at L5, you see the same runoff, but now we're opening up the ventrolateral space at L5, and I just think we need to consider it. It's a possibility. Here's another one. There's my catheter. And now there's the contrast going all the way down there. So I accumulated quite a few of these. Look at this one. Here's an L5 catheter, and I have contrast going all over the posterior suprailiac spine. So there are anatomic variations to people's anatomy where the spinal nerve roots are. There's scarring and inflammation that does really different things. It's even more complicated when you have multiple pain generators. Here's a ton of references. I don't have time to go through the studies. We're going to let you do that on your own. But the big ones have been Manchikani, Gertesmeyer in Germany, Dr. Hevner, who Dr. Rácz spoke about last night. The Gertesmeyer data came out now for 10-year follow-up. But I'm going to give you my best follow-up of all. This year, our practice saw patient number 94,000. 94,000. In our computer, in my office, there's 94,000 patients that have visited our center. 13,700 have gotten lysis procedures. If this didn't work, or this didn't really make a difference, do you think that many people would be coming to do this? So, yeah, we have studies, but remember, it's very technique related. And if you really give it a chance, there's a learning curve, but stick with it. You will find that so many patients who would end up with treatments that are far more invasive than this, far more risky. You don't want to talk about risk and complications? Let's talk about the risk and complications of that workers' comp patient I showed you that's permanently and totally disabled. So the treatments that a lot of these patients are going to end up with if we don't do this approach are going to be far more invasive and far more risk. I suppose you're wondering how I got changed out of my scrub so fast and to this desk here in Florida. I hope you enjoyed the presentation. My first question is, how often will I do lysis of adhesions for a failed back? And I'm going to answer the questions. They're being texted to me. That is the first one. Well, I do it quite often, but I think I do the procedure even more often for a virgin back. And one of the amazing things about this procedure, when I started doing it 20-something years ago, I felt that it was mostly indicated for a failed back, meaning you had surgery, you have scar tissue, you have adhesions, and this would be an appropriate procedure. The genius of Dr. Rácz really came to me shortly thereafter in realizing that inflammation causes scarring. And as I began to see and study my epidurograms from epidural injections, I could see, as I showed you from the presentation, that the dye wasn't spreading into the anterior ventral, into the ventral epidural space, ventrolateral. And then I realized that the inflammation was in fact causing the same scarring that you would typically see in a failed back, and began doing a lot of these procedures for virgin backs. Be that as it may, failed back is clearly an indication. It is a time where I'll do this very routinely. In fact, it will be my first procedure to do on a failed back that I'm treating for radiculopathy. So on a virgin back, on a non-operated back, I may consider transforaminals first, see if I'm getting good spread or an effect, and then switch over to a lysis of adhesions procedure. But on a failed back, I typically go right to the lysis procedure and bypass the epidural injections. The other thing I would want to mention about failed backs is the S1 catheter. It seems to be an amazing procedure that has been getting a lot of traction lately for me, especially in patients with hardware or those that I may not have gotten the best response with respect to the back pain. So if I've done a lysis procedure and the radicular pain is improved, but the back pain is still prevalent in a failed back, then I'll try an S1 catheter. Next question, please. The question is, do you get the same results with cervical lysis versus lumbar lysis? Yeah, I mean, I think the results for procedures in the cervical spine are more dramatic. I was thinking about that yesterday, in fact. I think pretty much anything you do in the cervical spine, assuming your diagnosis is correct, tends to do quite well. So no doubt, cervical lysis, same results, maybe better. Why not do a transforaminal on each level with spinal stenosis is the next question. Well, I do transforaminals on all levels with spinal stenosis, but I find that it's very common for these patients to have severe inflammation from the stenosis to get a limited response to transforaminals, and I very often will end up doing a lysis procedure. Next question. Next question is, can we perform adhesiolysis as a first treatment for radiculopathy? Absolutely. You know, as I said, for failed back, that is going to be my first line of treatment. I think you could say the same for a virgin back. Depending on what I suspect will be the case, I will sometimes do a lysis first, but I very often will also try a transforaminal to test the waters, see what the dye spread is going to look like, see what I'm getting initially. The other reason why I may try the transforaminal first is for insurance purposes. Sometimes they'll insist that be done first. Sometimes they don't cover the lysis procedure, so I'm trying to save the patient some money. I'll do the transforaminal first, but I think doing a lysis initially as a first-line treatment is very acceptable. The next question is, how do you decide between going in at sacral hiatus versus S1? Well, if I need to get higher up in the spine, I'm obviously going to do a caudal sacral hiatus approach. And S1, I'm typically going to do for either S1 radiculopathies or persistent lower back pain that hasn't responded as well as I wanted to with the caudal approach. The next comment is, that's it. Well, I hope I've been of some help, and I know that if you give yourself an opportunity to get through the learning curve on this procedure, which I have done and many others have done, it's a very important tool in the arsenal of weapons we have to treat people with these types of pain problems. Good luck to everybody. It's something you should really work at, and you'll be glad you did.
Why change the spinal cord stimulating needles? The answer is very simple. There have been rare but very nasty complications from more easily penetrating needle, where the tip of the needle, by the fact that it's a modified 2E one way or the other, the tip of the needle is bent. And very commonly, the working part of the needle is not the tip, but further back where the back cut is. And it's not something we looked for, but accidentally noticed when I used a Medtronic type needle, and because I only had one RX2 Coude needle, I could see both of them in the same patient at the same time and realized the advantages of the RX2 Coude needle. But what has led to the evolution of the RX2 was the recognition that virtually anybody who does spinal cord stimulator placements has had electrodes that went the wrong way, went into the subdural space, went to the subarachnoid space, and went into the cord. What a day. It really was almost magic to watch it. It looked like a space launch. You know, people sitting around modules, and amazingly we had a cadaver, at least the one I was working on, that was cooperating and allowing us to do things. It really was very gratifying that the questions that you guys have asked were great, and I would like to leave you with some thoughts that it is very important to learn how to examine the patient. It sounds sort of primitive, but it's not. you have to look at the patient, how they walk, listen to them, trying to help you make the diagnosis, because they're here to solicit your input whenever you are seeing patients. And most of the time, listening and then confirming. For example, straight leg raising is very important. Or if you have a patient that had a foot surgery or foot injury or any reason why they could not walk any distance, you have to incorporate evaluating their ability to squat down all the way and stand up. It is amazing how many times I have picked up a simple, and one of my patients came all the way from Munich, Germany, and the only thing I found on her was a saphenous nerve entrapment. So I did a saphenous injection, but even there you can do it right, wrong, in between, or terrible, or ineffective, or fantastic with a simple approach. You have to remember that primum non nocere. First, do no harm. It's very important that if you insist using a sharp needle where there are nerves and arteries bunched together, I mean, it's stupid. It's irresponsible. It's crazy. Like transforaminal. I had several fellows that ended up with paralyzed patients only because they don't stand up for what they should know better. And they just allow themselves to be pushed into it. Or doing a stellate ganglion block near the C6. So there's nothing at C6. Or why not do it with the Bella D, where you can aim it medially on the ventrolateral side of C6, the body of C6. You go between the trachea and the carotid, and we haven't had it haven't covered it today because we're all backs. But if you go and don't extend the head, just neutral, pull the carotid sideways, a finger breadth below the cricoid, and go down aiming slightly medially, and then rotate the sealed-ended Bella D laterally, put 5 cc's in, you will block the stellate ganglion right there. And then you rotate the next 5 cc, rotate it down towards the T2-3. And it strangely will go right down there where you point. It's like a jet. And use the contrast. 1 cc is plenty. So you have a 3 cc syringe with a bit of contrast with the double Nelson catheter. So you inject a little bit of contrast, then you inject 5 cc's of local steroid. And then you rotate the needle, then inject without touching anything, hold it with a Kelly so that your hands are not in the X-ray. And inject 5 cc and go straight down to the sympathetic ganglia of T2-3. So 45 degree down, straight lateral. We haven't covered it today. Do the dural tug. You'll be amazed. Look for ability to stand on tippy toes. And if they can, then you do it on the painful side. And if they can, fine. They don't have a motor weakness. But if the foot is shaking, then there is a serious consideration for the scarring triangle. I loved Dr. Fox's comment when he made the realization that he expressed it to you so elegantly that he looks for spread to the ventral, lateral, or ventral epidural space. It's hugely important. There is a belief that surgeons, they don't really do much fluid injections, contrast in epidural space. That there's an assumption that if you inject in the posterior epidural space, that spreads to the ventral epidural space. Not so. But if you inject in the caudal epidural space and watch it go up, it will tell you the diagnosis. And that's where you have to go mid-canal with a transforaminal catheter and watch your results multiply and long-term, and watch the disappearance of the immediate post-procedure pain. Now, we have a major issue trying to get the word out that any significant pain that lingers on, it is incorporated in the handout for the dural flossing post-procedure physical therapy. What we do is nowhere near as good as it could be, especially if you don't instruct the patients on post-procedure dural flossing exercises. I put on the dural mobility that made me amazed when I discovered this about 5 years ago, that I had this patient with 3 electrodes, and all I wanted her to do is to rotate the head and a bit of chin to shoulder. Well, this is not quite the dural tug that I really want to go bend, stretch everything forward, and then move down midline, out way laterally. Now that's for the dural tug, that when you pull on it, the patient will put a finger exactly where it hurts. And it's in the book where the patient pointed exactly to L2, and I bet you couldn't give me an L2 painful indication secondary to epidural scarring. Well, let me tell you, this was a patient had a partial nephrectomy some times before, and subsequently had massive pain, regardless what doctors did. And we realized that this was after a partial nephrectomy. There were lots of hemoclips in surrounding L2, and all I had to do is, first of all, do a epidural spread and placement of the catheter towards L2 from below L3-4, and when I went up, get to L3, she says, oh, and then we go to L2, it was really painful. and opened it up, and this was 5 years ago this coming February. And she's been doing pain-free, even though she had transforaminal endoscopic discectomy, had numerous doctors, and nobody got the diagnosis because nobody did a dural tug. And the dural tug I marked the day before on the skin, and day of the procedure, I wasn't sure what the hell I was going to do. And I knew it more or less somewhere in the vicinity, but then I did the repeat dural tug, and she put the finger exactly on the spot she put it in the day before. So I knew there is the pain generator. One patient, it's in the multiple books we've put out, a 13-year-old girl who was in a hospital and left-sided belly button pain, and they watched her, observed her, and took out her gallbladder, which is right-sided pain usually. Didn't do anything. Then took out her appendix. Didn't do anything. And told the mother and the little girl, and we have nothing further to offer, go and see a psychiatrist. And when eventually they came to see, they did an examination. I put her in a dural tug position, bending forward, and moved the head and neck, and she pointed exactly to T9, 10. And did an MRI, there was a minimal change, so went to T9, 10, and massive scar tissue. So because it was going on for years, and little girls can get big girl pains, but it could be a flexion injury. So there are things where your examination sets you up for what you do. But one of the most important and common, these are rare as hen's teeth, but common things are common. And when you do a caudal neuroplasty or contrast injection, you have to do 10 cc's. And then you do 10 cc hyaluronidase. Then you do 10 cc local anesthetic. And what you must do is you must look in the lateral view. And being on the lateral view, you see where the pain is coming from. You have to go and open it up, and how do you do it? You can do it with a curved blunt needle, through an introducing needle, a 2-needle technique, or you can do it with a catheter with a 3 times hypertonic, but you will be getting unbelievable responses where everybody has failed. So these are some of the thoughts in closing. Not meeting you guys individually is a bit regrettable, but I believe you will be a changed doctor, you will be a better doctor, and my best wishes to you all. God bless you, and we look forward to our series, and it is worthwhile to be provoked and insulted to get along the same ideas that we have. Thank you very much thank you for coming, and God bless, and be safe, and happy masking for a while longer. God bless.